بسم الله الرحمن الرحيم. Dear Professor and colleagues, الأستاذة الدكتورة ماجدة مراد، الأستاذة الدكتورة مها الزعفراني، الأستاذ الدكتور إكرام حامد، Chairperson of this session. لو تكرمتوا يا جماعة اللي يعني نقفل الباب ونركز كده شوية عشان السلايدز. Slides please. First of all, it's my great honor and pleasure to be the first presenter in this 5th Breast Cancer Bahia Center conference, and I wish all the success and congratulate all the people who are behind this meeting, and I congratulate all groups working in Bahia Hospital to support breast cancer women all over Egypt. Okay, so in the next 20 minutes I will try to address some very important question when we are mentioning neoadjuvant. Now neoadjuvant is a trend for all breast cancer women, and this usually discussed every day in multidisciplinary meeting. So when we are talking about okay, ممكن استخدم ده أحسن. Okay, so usually يعني run on our mind some question. Do we apply for any stage? So it is for only axillary positive tumor or axillary negative, for young versus old patient, and if we convinced which regimen to which patient, how many cycles, close evaluation and clip insertion is needed, or we decided to mastectomy and no need for clip insertion, and what if we apply neoadjuvant and we have a residual disease. And I think this will be covered by my dear Professor Dr. علاء أنديل. أهلا بك يا دكتور علاء، نورت القاهرة in the same session. Okay. So historically, neoadjuvant was planned for inflammatory breast carcinoma where even mastectomy is impossible. And by doing this many years, we discovered that some stages can be better cosmetic appearance by more breast conservation. So it is applied in a wider group of patients. And for us as a physician, it gives us an idea that this tumor is sensitive to such regimen. So this is in vivo test for each patient. And by doing more and more neoadjuvant, we discover that group of patients enter in complete pathological remission, which is complete disappearance of any invasive component in both breast and the axilla. And this was amazing. So we eradicate the disease early before touching hair by surgery. And by doing some study, we discover that pathological CR is a projected and very independent and the surrogate marker for more survival for such women and less presence of any event in the future. So it is well established that pathological complete remission. Okay. So it is well established that PCR or pathological complete remission is a very valid surrogate to long-term survival. Information on the outcome associated with pathological CR in this setting allows switching from an ineffective regimen to a more effective regimen. And now more and above, we allowed to do more regimen or more chemotherapy or another line of chemotherapy, even if the patient is not responding, just because to allow us or to gain pathological CR. The aim of each patient when we start chemotherapy or endocrinal treatment as neoadjuvant is to attend him in pathological CR. And we divided the patient later on to PCR and less than PCR, as if PCR is our goal and our dream. Okay. هو الحقيقة أنا مش ممكن حد من الاي تي يساعدني عشان انا الظاهر مش شاطره قوي في الحاجه دي. ممكن اعمله بالكرسر عشان ده حساس شويه.
حضرتك عايز ترجعي؟
عايزة ارجع. لقدام ولا لورا كده؟
كده لورا.
طب ما ينفعش من هنا؟
هو الكرسي شغال عادي.
بس انا رحت في حتة تانية. لا انا كده رحت في حتة تانية، انا كده عايزة اطلع بدري.
استعدتي؟
لا كمان. اوكي، يعني لما ادوس ده كده اكنه لقدام وده لورا.
ده لورا وده لقدام وده سبوت لايت.
Okay. So we talk about pathological CR and why I'm telling that, because this is not just something it is observed, it is documented in many meta-analyses. They pooled many patients. This is meta-analysis for 11,000 patients, and they're not looking for pathological subtype. They are looking only for patients who attend the pathological CR after neoadjuvant or not attending pathological CR, and this is highly reflected on the disease-free survival. This is a green curve, or the overall survival. So any patient attending pathological CR, whatever the pathological subtype, have a better event-free survival and, of course, very different overall survival, and this is more than 15 years. So this is meta-analysis give us the impression that we do all effort to attend pathological CR in our patient. So now it is wider and wider. Nowadays, adjuvant role is constricted and the neoadjuvant is wider. For any group, for inflammatory breast carcinoma, T4 of course, and T3 of course, stage 3, and sometimes in very special subtypes, even in very small tumor like triple negative breast cancer and HER2 new positive. And what about luminal? Luminal is still in the gray zone, and I will cover it in very few slides later on. If there is any contraindication to the neoadjuvant, of course, multifocality. Very obese patients, we sometimes prefer not to do neoadjuvant because we will not overhair breast conservation and no radiotherapy. Sometimes residence of the patient or patient choice even, and we have to enter the patient in our decision. And if you started neoadjuvant, please complete all the cycle. There is no good response and go for surgery, even though if it is completely resolved, we have to complete the neoadjuvant. So this is a new, and this is a recommendation from the last ESMO. Neoadjuvant chemotherapy equivalent to adjuvant chemotherapy in all patients. Yes, and there is many studies comparing this. If we do neoadjuvant and no residual, no need for adjuvant. And then many years ago, the surgeon raised a question that adjuvant and neoadjuvant is the same in the survival and disease-free survival, so why we delay the surgery? And the question now that in many meta-analysis, when the patient follow-up is long, no neoadjuvant is better than adjuvant because it treats macrometastatic disease and bring more conservation, breast conservation to the patient. And then the question comes, so this statement is general. For what type of the patient we decided to do neoadjuvant? Of course, for triple negative disease, and for HER2 positive disease, and in high risk hormonal receptor positive disease. And sometimes we are very reluctant to give neoadjuvant, not because of the patient or comorbidity, but because of hair subtypes. We will know now that luminal group or hormonal dependent tumor not entering in a high percentage of pathological CR. So in many cases, we can start adjuvant and do surgery and then go for neoadjuvant. And this is the only exception in nowadays is that many of us approved adjuvant first before neoadjuvant. Okay. So how to choose and how to predict and how to do a daily mental exercise in MDT. we will discuss with us the possibility of this patient to recurrence. It's very near to the skin. It's have a maxillary lymph node or pathological subtype, or the disease is long-standing, or she has a family history, she is young. All these factors must be put in mind while choosing a neoadjuvant treatment. And in the last or the end of the day, it will be a MDT choice or discussion, putting the biology, of course, and the age of the patient, tumor size, lymph node, and the comorbidity as a factor to decide it. We have to know that pathological complete response usually occur or happen in a highly proliferative disease. And this is very clear in the HER2 positive and in the triple negative disease. The first row where ER and PR positive, here is HER2 negative. We have a lot of patients here in the population, but only 8 of them can be entered in pathological complete remission when treated with chemotherapy. When the patient have HER2 overexpression and the hormonal dependent tumor referred as triple positive, a minority of the patient, and very little of patients can enter the less than 20% pathological complete remission. If we see a HER2 positive disease where hormonal negative tumor, it's 40% or it's almost the double amount of the patients that can enter in pathological complete remission after chemotherapy. And this is indicate or clarify that HER2-enriched group of patients with non-sensitive hormones must be treated upfront with neoadjuvant chemotherapy, and this is proved in many trials. And here is a triple-negative disease because it is little bit aggressive tumor and may have a worse prognosis, but they are responding and enter in pathological complete remission, and this is a very big indication to give them preoperative chemotherapy. So what is neoadjuvant in HER2 positive disease? We have to convince ourselves that we have many trials, and in this trial it's clearly enough, and this is all the neoadjuvant for Herceptin trial or trastuzumab, NOAHA trial, where the preoperative chemotherapy versus no trastuzumab, it's very clear, the red curve versus the green curve, and here is a pathological CR, breast and node, 38% in the trastuzumab or Herceptin group versus chemotherapy only 19%. And this is old, and by this study, all patients with HER2 positive disease must have trastuzumab in their adjuvant disease, in their neoadjuvant setting. Okay, and later on, 5 years later, the dual inhibition of HER2 was very evident with good response or good effect on the metastatic setting, and started to be applied in the neoadjuvant setting. By dual inhibition, I mean trastuzumab, pertuzumab, and here is a trial of Neosphere that is clearly identified that addition of pertuzumab with HER2 with trastuzumab can enter the patient in a higher pathological complete remission. And here the orange column is the winner when by addition of Taxol carboplatin with, this is a chemotherapy, with Herceptin and Perjeta, we can obtain the 45.8% pathological CR both in axilla and breast before surgery. Okay, and here pathological CR rate in the Neosphere, it's very clear. It's very clear that trastuzumab, the very right-sided trastuzumab and pertuzumab, the very right-sided column, 17% for all group. But when we subset the patient to hormonal sensitive and non-hormonal sensitive, it is clear that the group which have no response to the estrogen receptor enter in a pathological CR, 63% here 63%. A very big amount of patients can be treated with trastuzumab and pertuzumab, and this subset analysis help us for patient selection when choosing patients who can offer them trastuzumab and pertuzumab as well. Pertuzumab is now a standard treatment in the neoadjuvant setting for HER2-positive disease, of course, and the recommendation that we usually choose node-positive, ER-negative disease, and this is a standard of care of them. Should we reduce therapy by using response to neoadjuvant therapy as a biomarker? This is very important and very intelligent. All big trials, they do chemotherapy, but on the backyard, they do some laboratory and some genetic analysis that can help us. While the patient entering in pathological CR, this is not enough because this is a normal lady. How much they stay free and for how many years they will survive. So we can predict from the response and the biological marker on the specimen post-surgery the importance and the value of addition of neoadjuvant treatment. What about triple negative? Triple negative is highly proliferative disease, and also many questions arise in mind. What we shall give them a neoadjuvant? Of course, yes. What type of neoadjuvant shall we add? Platinum compound, and is this affected disease-free survival and the overall survival by putting them in PCR? And this is very important curve. I showed, and everybody showed it many times. The green curve, while the patient, whatever their pathology, enter in pathological CR. And then they started to look to triple negative, entering PCR or non-PCR, and they found that triple negative disease, when I offer them neoadjuvant and enter in pathological CR, can act like the other non-aggressive type of pathology. And from this point, we are convinced, or many center convinced, to give neoadjuvant in triple negative as well. So the question of containing platinum or not, very important GPARA-6 trial. This is a German group working on the neoadjuvant. They offer the patient paclitaxel, liposomal doxorubicin, bevacizumab with carboplatin, and the other arm no carboplatin. And they offer these two both. They offer this to triple negative and HER2 disease patients. Among 595 patients, the importance of carboplatin is very clear, but it is not statistically significant. In triple negative, okay, ده بيقلب لوحده بس okay. خليكي بس قاعدة جنبي، هو انتوا الترانسميشن بتاعكم ضعيف شوية. triple negative خلاص عملتيها؟ Triple negative disease, 315 patients. It is very clear that addition of carboplatin puts 53% of the patient in pathological CR, and this is statistically significant. After 5 years disease-free survival, 76 versus 85 in the carboplatin arm. GPARA-6 trial show better outcome in patients with triple negative with addition of carboplatin. And the important thing in this trial, this is independent of germline, because many of you will ask me, can we add platinum for just BRCA mutant triple negative? And the answer here is very clear. It is not for BRCA mutant, for all population or all newcomer. Okay. Many workers would like to reproduce the same effect or the same, and this is I-SPY 2, where they included 460 patients. Standard chemotherapy versus carboplatin and chemotherapy improve the pathological complete response, and this is again significant. GPARA-6 and CLAGB trial, where the standard chemotherapy in the triple negative setting offer 41% pathological CR, and this is when addition of carboplatin is 54%, and it's again significant. And recently, in the era of immunotherapy, triple negative as affected group of breast cancer, they started to use immunotherapy in this group in metastatic setting, and it's proved effective. And nowadays there is many recommendation to use immunotherapy in the neoadjuvant setting to improve the outcome and disease-free survival. Okay, 1 minute I will talk in Arabic. مشكلة الادجuvant and neoadjuvant علشان الشباب الصغيرين اللي قاعدين, she is a normal lady. We eradicate her disease by surgery. مفروض ان يكون حلمنا ان she live as long and her quality of life as her socio-economic related age and gender. So this is normal lady, and we would like to add more and more. فرصتنا الحقيقية ان احنا eradicate the cancer and bring a better cure is to play good and play very precision in the neoadjuvant setting. Okay, so this is immunotherapy, and we can discuss for many hours. You convinced us to give a triple negative for any stage, even though if it is T1, and there is a great debate in the literature and a great debate every day in the multidisciplinary team, when the patient discovers herself by mammogram during screening and it proved triple negative. Shall we give her again a neoadjuvant combination of all this chemotherapy and the immunotherapy? And the question is there, and we have to react. In a very few minutes, I will cover luminal. Luminal breast cancer in the neoadjuvant setting is a gray zone, and it is very big debate nowadays to give or to start surgery. We notice that the luminal is not responsive to chemotherapy, and we can offer them neoadjuvant endocrinal treatment. And this slide from the last European breast cancer 1 year ago. This is Martin Picard telling us that luminal breast cancer, we start with aromatase inhibitor for post and premenopausal. And I stress on premenopausal because sometimes when you find patient premenopausal, you give her chemotherapy without saying her biology, and this is not right. And by doing aromatase inhibitor, we can add, if there is PI3K mutation, we can add in the neoadjuvant anti-PI3K inhibitor, or we can add to the aromatase inhibitor CDK6 inhibitor. And we can think about the patient with many aspects: her comorbidity, strength of steroid receptor, and this is very important, how sensitive she is to estrogen receptor and progesterone, and histological grade. It's very important to look for the grade, tumor size, and axilla lymph node. We have another tool to help us, but this is not applied in Egypt, to do genomic test, and it is now approved in the neoadjuvant, not only for adjuvant. But by genomic test, we are not reaching a very clear conclusion. Still, tumor size and patient is very important. This is from the last ESMO 1 month ago, how to predict the value of neoadjuvant, as is the genomic test is enough, and the answer is no, it is not enough.
Dora Heba, your time is out.
Okay. I can put my conclusion, or...
Okay.
في عجالة سريعة، مش بس الجينوميك تيست، لكن لازم نفكر في أشياء أخرى. KI67, one of the biomarkers that we can depend on it in the neoadjuvant, with many literature about the KI67 in univariate and multivariate analysis, and this is very recently from the last ESMO. And الناس بتفكر دلوقتي في الluminal إنه we can offer them endocrinal treatment and then see the response. If the response is good and the grade is not increasing and is still responsive to chemotherapy, to endocrinal treatment, we can continue by endocrinal treatment, and this is referred to PIPA score of evaluation. What I need to tell you, and I entered in an international trial with Dr. Ala Andil. This is Sophia trial, and this is the conclusion. But my take-home notes that before doing any neoadjuvant, we have to look for the biology. We have to discuss each patient by her all factors. All planned chemotherapy must be given upfront to enter the patient in pathological CR. We have to look for Ki-67 in each patient. Multidisciplinary approach is very, very, very important. And here is a very rapid diagrammatic how do we deal with a patient when we look for the biology and discuss in MDT. And for this, and I think, Yani, thank you very much.
Thank you, Dr. Heber, for such a fruitful information and talk. And now the next speaker is Dr. Rasha Kamal, and her talk is about the fears and pitfalls in assessing response to neoadjuvant therapy.
The challenge in breast imaging is not only to diagnose the underlying cause behind breast symptoms, but it is how to apply the best practice to do so. And to be able to do so, we must be able to choose the appropriate imaging modality, and we must be able to correlate what we see in this modality with the clinical data and with findings in other imaging modalities. And from this perspective, I'm going to discuss with you today the role of imaging in assessing patients receiving neoadjuvant therapy. Candidates for neoadjuvant therapy include locally advanced disease, patients with smaller tumors aiming for better cosmetic outcome, and some molecular subtypes of breast cancer like the HER2 and the triple-negative breast cancers. Pathological complete response and tumor downsizing to allow for more conservative surgeries are the main targets to neoadjuvant therapy. The complete course of neoadjuvant therapy usually entails months of administration of different chemotherapy drugs, and the early prediction of tumor response is vital for the oncologist to decide whether to stop further unnecessary drug administration or to change the line of management in non-responders. We as radiologists play a fundamental role in the follow-up of patients receiving neoadjuvant therapy, where in a tumor board we should tell the oncologist whether his patient is a non, partial, or a complete responder, and according to this the oncologist might keep or change the line of management, and he might have some prognostic information about the patient. We should also tell the surgeon about the relation of the tumor to the skin, to the nipple, to the chest wall, the lesion multiplicity, and the size of the residual disease, and by this the surgeon can plan for his surgery, whether conservative surgery or mastectomy. The way that we assess the response is called the response evaluation criteria in solid tumors, known as the RECIT, where we say a complete response means that there is disappearance of all lesions and pathological lymph nodes. Partial response is a decrease of equal to or more than 30%. Stable disease is neither partial response nor progressive disease, and progressive disease is increased more than 20% in the sum of the target lesions. The methods that we use in assessing response is breast clinical examination, mammography and ultrasound, contrast-enhanced mammography, MRI, and PET mammography. And in this lecture, we are going to weigh the pearls and the pitfalls of each of these modalities. We'll start by the breast clinical examination, and as we see, the pitfalls of the breast clinical examinations outweigh its pearls. Breast clinical examination is often called a deceiving tool, as it can under and overestimate the presence of residual disease. It is reported that 45% of complete clinical responders had residual disease at histological examination, and in the same time, 60% of patients with complete pathological response had clinically palpable residual disease due to necrotic residual tumor mass. And to balance the pitfalls of breast clinical examination against its pearls, we should add the pearls of breast imaging. This is an example of a 40-year-old female with a left paraareolar invasive duct carcinoma grade 2 with adjacent multiple small-sized cysts. For the first look, we might think that this is totally the mass, but looking closer, we will see that this is the mass, and there were adjacent cysts just next to the mass, and when the clinician palpated this, he felt that the tumor is larger than the actual size of the tumor. And to further prove this, this is the MRI of the patient showing a single enhancing mass lesion. For the clinician, it was a T3 tumor, but actually on imaging, it is a T1 tumor. After giving 2 cycles of neoadjuvant therapy, the clinician again felt that there is no response, so he sent the patient for imaging. We performed a contrast mammogram, and actually there was marvelous response. Before the operation, she was sent again to evaluate the residual disease, and when we performed, there was complete radiological response. Mammography, the second modality is the mammography and the ultrasound. To evaluate response on mammography and ultrasound, we assess the decrease in length of the largest mass according to the RECIST criteria. To be able to do so on a mammogram, there must be adequate contrast between the tumor and the surrounding normal tissue, and this is only feasible in ACR-A and B breast densities. This means that we can assess the response of most non-circumscribed masses. We cannot assess the response for most non-circumscribed masses, areas of parenchymal distortion, and lesions in dense breast based on a mammogram alone. Even when we add ultrasound, it was also found to be non-reliable in evaluating the size of residual tumor, except for evaluating the regression of edema and skin thickening and in assessing the response in the axillary nodes. And by far, ultrasound is the best modality to do so. When the tumor is fractionated, multifocal, or when it is larger than the field of ultrasound probe, the ultrasound measurements become more unreliable. Necrotic residual tumor mass are hypoechoic on ultrasound, giving a false positive impression of residual disease in patients with complete pathological response. This is a screening mammogram of a 53-year-old female. Actually, in this case, we do not need to inject contrast media because there is actually natural contrast between the dense breast mass and the surrounding fatty breast parenchyma. It was an indeterminate lesion, and when we applied the artificial intelligence, it took a score of 99%, which means that this lesion is most probably malignant. She received her neoadjuvant, and after receiving neoadjuvant, the patient came. There was complete radiological response. The AI, we see nothing marked, and if we have a closer look, this is a screening mammogram of a 53-year-old female. As we said, there is natural contrast between the mass here and the surrounding fatty breast parenchyma, so we do not need to inject contrast media. And this was the AI giving the same mass a score of 99%, which means that this mass is most probably malignant. After receiving her neoadjuvant chemotherapy, as you see in the artificial intelligence, the mass has disappeared, and in the post-neoadjuvant mammography and ultrasound, the mass also disappeared, and what we only see is the clip which was fixed at the site of the previous mass. On the contrary to this case, we have this 40-year-old female with a left breast mass. This is her pre-neoadjuvant chemotherapy films, and she had a heterogeneous dense breast parenchyma where we can hardly say that she might have a lesion here which is only seen in the CC view and not in the mediolateral oblique view. This is the post-neoadjuvant study, and again, it's difficult to get any information from her mammogram. Well, look how easy it is to look at the post-pre and the post-neoadjuvant contrast studies. We can easily say that we have a multicentric disease which has shown partial response. And from this, we must confirm that the best results in breast imaging are usually obtained from modalities which can combine an enhanced morphology assessment together with some functional information. And getting this functional information is either by the injection of contrast media, like the contrast mammography and MRI, or by assessing the metabolism of the cells, like what we do in PET mammography. And again, to balance the pitfalls of sonomammography against their pearls, we have to add contrast to the mammography. And so we'll move another step. And we will have now to discuss the contrast mammography and the MRI. In a study performed by Lotti, they concluded that contrast mammography could provide an accurate assessment of tumor response and residual disease after neoadjuvant therapy, with an accuracy that is comparable to that provided by MRI. The disadvantages of contrast studies in general are the renal toxicity, possible allergic reactions, and adding time and cost to the examination. A question that I'm commonly asked in tumor boards: when to use contrast mammography and when to use contrast MRI in the follow-up of patients receiving neoadjuvant therapy. And to answer this question, we're going to make a simple comparison. Contrast mammography is less time-consuming, better tolerated, with a relatively lower cost. It is easier to interpret, and one main advantage is that we can still assess the microcalcifications on the low-energy image. But we have to admit that by far MRI is still the top-notch modality in breast imaging because of its multi-sequential and multi-planar imaging, which allows better lesion characterization. But actually, looking at a patient already diagnosed, we do not need this advantage of MRI. So whenever you have contrast mammography and MRI, follow up your patient with contrast mammography, not MRI. But we have also exceptions to this. If the lesion is deeply seated in the axillary tail or inframammary fold, we call these areas as mammography hidden areas. So it's not preferable to perform a contrast mammography in lesions situated at these sites. This is a high-risk 30-year-old female with a palpable left breast mass lesion. All what we see on her mammogram are these microcalcifications in the left breast. We prefer to perform an MRI for this patient, and it showed a multifocal malignant mass lesions that were adherent to the overlying skin. This is another sequence that we use in MRI, and it is considered one of the indicators to assess neoadjuvant therapy, and this is the diffusion-weighted image. And a lesion which appears bright on the diffusion image and then it becomes dark in the ADC is said to have a restricted diffusion, and most probably this lesion is malignant. She received her neoadjuvant and she came for the preoperative assessment. As we see, there is partial response of the lesion. And if we look at the diffusion-weighted image, now there is no lesion showing any restriction. This is another 47-year-old female with a palpable left axillary tail mass that was proved to be an invasive duct carcinoma grade 3. The lesion is seen only in the MLO view, and to see it clearly in the CC view, we had to do an additional view, which is the extended CC view. This was how it appeared on ultrasound, and as I told you, the ultrasound is better than any other modality in assessing the lymph nodes. When we applied the artificial intelligence, it marked another lesion that was anterior to the main lesion. We went back to the mammograms, and we discovered that we missed microcalcifications extending in a linear attitude. We performed an MRI for this patient because it is not preferred. If I have to do additional mammography views, this means that the lesion is hardly seen on the mammogram because it was deeply seated within the breast. So we preferred to perform an MRI which showed the mass and anterior non-mass enhancement. These are the pre and the post-NAC images, MIP images, and as we see, there is complete radiological response. A wire was fixed before the operation, and the mass was conservatively removed. This is another case, 29-year-old with a palpable left upper outer quadrant mass proved to be triple-negative invasive duct carcinoma grade 3. As we see on the mammogram, we cannot assess the size or the extension of the lesion. And this was her ultrasound examination showing the mass and the pathological axillary lymph nodes. On the contrast mammogram of the same patient, it is very easy to assess the size of the lesion. This was the post-neoadjuvant studies, contrast study, again showing partial response. And this was the ultrasound examination showing a partial response of the mass and of the axillary lymph nodes. In spite of having so many modalities to assess the response to neoadjuvant therapy, Unfortunately, even with the best imaging modalities, we still face some difficulties. For example, we have, this is the pre-neoadjuvant and the post-neoadjuvant study of the same patient showing, should we say there is no response based on the RECIST criteria, or should we say there is partial response based on the fact that there is decrease in the intensity of the contrast uptake? This is another case. This is the pre-neoadjuvant and the post-neoadjuvant. Again, we say that this case, she's a responder because the lesion has regressed in size, or is it a progressive disease because she has developed a new mass during her neoadjuvant therapy? And again, to outweigh the pearls of contrast studies against their pitfalls, we have to add the pearls of artificial intelligence. Artificial intelligence is rapidly progressing from just preliminary studies into actual clinical applications. By using AI deep learning tools, we can extract quantitative and qualitative parameters from medical imaging beyond what can be perceived by the human eye. Several successful AI technologies have been introduced in 2D mammography, mainly in lesion detection rather than interpretation. Yet there is paucity in literature exploring the potential impact of adding AI models to contrast mammography. And for this reason, a memorandum of collaboration between GE and Bahia Hospital was signed to develop a contrast-based artificial intelligence quantitative tool to assess the response of malignant breast masses to neoadjuvant therapy. This is the pipeline of the study. We collect first the pre and the post neoadjuvant images. A comparison and a registration tool was developed, followed by development of an automatic detection tool. And now we are in the process of developing a quantification tool which can assess the residual viable disease, the length evolution, and the surface evolution of masses. And this is very important for the important information for the surgeon to know. We're going also to add some clinical information to give the oncologist some prognostic data about his patients. This is a triple negative breast cancer assigned for neoadjuvant chemotherapy, and as we see, it's difficult to assess the size of the lesion both in the pre and the post-NAC images. The pre and the post-NAC images are first registered, and when we say registered, that we make both studies typically fitting or overlapping to each other. And then they are compared for changes in signal intensity. The signal intensity is then represented on a color-coded scale from red to blue. If the lesion takes a blue color, then this lesion is regressing in size, and if it takes the red color, it is progressing in size. This is another case of a progressive breast cancer. As we see from the pre-neoadjuvant and the post-neoadjuvant films, that we see that the mass has increased in size. If we look at the lymph nodes, we will find that the lymph nodes have regressed in size, and that's why they take a blue color, while the lesion itself is progressive, and therefore it took a red color. We also developed a detection tool which can automatically detect lesions on the recombined neoadjuvant images using deep learning algorithms at a sensitivity of 95% for detection of cancer. This detection tool is also associated with an abnormality score which can help us to discriminate malignant from benign lesions. And lastly, we are in the process of developing the quantification tool, and using the quantification tool, both the length and the surface length evolution can be quantified and can be automatically computed. This is an important information for the surgeon to plan for his surgical approach. And now we come for the last modality, which is the PET mammography. PET mammography is a specialized application of PET to visualize breast tissue metabolic changes with a much higher spatial resolution. It is still under research in Bahia Hospital to test its validity in the follow-up of patients receiving neoadjuvant chemotherapy. This is a 33-year-old female with a high-grade triple-negative breast cancer. This is her pre-neoadjuvant study, and this is the post-neoadjuvant study, showing complete radiological response. This is another 20-year-old female with high-grade triple-negative breast cancer. This is the pre-neoadjuvant films, and these are the post-neoadjuvant films. This is the post-neoadjuvant films. And as we see in this case, we have partial response. And one advantage of PEM is that we not only assess it morphologically, but we can do also a quantitative assessment by measuring the PUV and the lesion to background activity, which gives us more quantitative data for the amount of response. In conclusion, there is definitely lack of agreement on the optimum practice guidelines for how to assess the response of malignant breast masses to neoadjuvant therapy. Given the increasing volume of breast imaging and the continuous and rapid development of breast cancer treatment options should open prospects for research to set appropriate guidelines. Yet the current evidence suggests that the most accurate and clinically impressive imaging tools are those which can provide combined anatomic and functional information. Thank you.
I really appreciate the opportunity of being here with you today to discuss a topic which is relevant to all oncologists, pathologists, and surgeons as well, which is how we evaluate breast cancer after chemotherapy and what are predictors of complete pathologic response. Neoadjuvant chemotherapy was initially used in locally advanced breast cancer in order to convert inoperable tumors into operable. However, it's now increasingly used in earlier stage disease for patients with larger tumors with a goal of shrinking the tumor to avoid mastectomy and using breast conservative surgery instead. Neoadjuvant chemotherapy is also used in order to avoid axillary dissection and to convert patients into sentinel lymph node biopsy instead. Another very important goal of neoadjuvant chemotherapy is the vivo real-time assessment of tumor response to treatment. It's now known that long-term outcome of patients is similar regardless whether chemotherapy is given before or after surgery. On the other hand, patients who achieved pathologic complete response, which we call it PCR, have a significantly better outcome than those without a PCR. Finally, FDA uses response to neoadjuvant chemotherapy as a short-term endpoint on clinical trials to approve a new oncology drug. There are 4 possible ways for a tumor to respond to neoadjuvant chemotherapy. First, to achieve a pathologic complete response, PCR, or partial pathologic response, or no response and stable disease, or disease progression. In the best case scenario, neoadjuvant chemotherapy is highly effective. All tumor cells are killed, the entire tumor melts, and the only thing that's left behind is the tumor bed, as we can see here in both gross and the corresponding microscopic picture of the excised specimen. Tumor bed appears microscopically as an area of hyalinized diffuse hyalinized vascular stroma, diffuse fibroelastosis, foamy histiocytes, and sometimes calcifications, with no evidence of any residual viable tumor cells and no normal breast ducts or even no normal breast lobules in this area. It's documented that full resection of tumor bed is not necessary. However, when a resection margin is involved by tumor bed, as we can see here, the inked margin is involved by free tumor bed. If in such case, we should document this in the pathologic report. However, this does not mean that we need extra margin. But if in such case there is still viable scattered tumor foci present, we may ask surgeons for more generous margins. In some cases where tumor bed is invisible, pathologists should properly palpate each slice of breast tissue to find the clip. Also can use a specimen radiography with the aid of preoperative radiologic and clinical data. Sampling of the correct area can be confirmed microscopically by identification of the clip site granulomatous reaction, as in these microscopic pictures. Let's see what will happen if there is no PCR and only partial pathologic response is achieved. In this case, we have some tumor cells are killed by tumor, but most of tumor cells are still surviving and left behind. There are two scenarios of how could this happen and how could this look. First, the first scenario is what we call it concentric shrinkage. That means that tumor shrinks to more or less the extent as the shape as before, just smaller in size. In this scenario of partial pathologic response, tumor has been shrunk to the extent that solitary confined focus or some clusters of residual tumor cells with intervening therapy-related fibrosis left. However, it's still confined to a single area. But in the most common scenario post-chemotherapy is the residual, we can find residual scattered tumor foci with intervening therapy-related fibrosis like this. And in this scenario, the diameter of the original tumor bed should be known from the initial pre-therapy radiologic data. In this case, total tumor size is measured, as we can see here, to include this residual tumor cells found outside the tumor bed. And according to the 8th edition of AJCC staging system, the largest continuous focus of invasive carcinoma, like this, should be measured for T stage. This diagram illustrates how we adjust tumor size after reviewing the microscopic slides from the grossly detected tumor bed. In this example, the pink area is the macroscopic or the grossly detected tumor bed, and the blue dots represent the actual tumor size after reviewing microscopic examination. For this reason, pathologists should submit the largest cross-sectional area from the detected tumor bed. In the first example, as we can see here, there is a big obvious tumor bed where 5 representative sections is sufficient, and the average cellularity from each slide can then be estimated. While in the second example, where there is a vague tumor bed, systematic sampling should include the visible tumor bed and the immediately adjacent normal breast tissue. This is to represent the whole area expected to be involved by carcinoma before treatment. The evaluation method for axillary lymph node is the same as that for non-neoadjuvant cases. And for sentinel lymph node, they should be sectioned in 2 millimeter intervals and embedded as such for microscopic evaluation. In some cases, metastatic tumor cell cluster post-chemotherapy can be only identified by immunohistochemistry for cytokeratin, because we can't see this by microscope, so we can use immunohistochemical reaction for cytokeratin to identify these cells. What about presence of isolated tumor cell metastasis within lymph node post-chemotherapy, as in this picture? Isolated tumor cells are defined as a deposit of less than 200 tumor cells or less than 0.2 millimeter. In such case, where isolated tumor cell present post-chemotherapy, according to the AJCC system, it is staged as negative node, YP and 0I+, and this precludes PCR. However, the WHO recommends to classify such lymph nodes as positive. There are multiple classification systems that have been proposed for evaluating pathologic response after chemotherapy. As we can see here in this table, some systems evaluate the breast only, but most of systems evaluate the response in both breast and lymph node. Also, in most of these systems, the presence of DCIS only after chemotherapy qualifies the complete response. However, other researchers argue that residual DCIS might lead to high local recurrence risk after chemotherapy. The most widely used systems are the AGCC system and the residual cancer burden system. Residual cancer burden system was developed in the MD Anderson system, Cancer Center. 5 pathologic parameters are assessed by the pathologist and then incorporated into this free online calculator, which is available on the MD Anderson website. These parameters are the tumor bed size, overall residual cellularity, percentage of residual DCIS, a number of positive lymph nodes, and the diameter of the largest metastasis within lymph node. The calculator then generated both residual cancer burden score and classes, which range from 0 to 3. Residual cancer burden class correlated with patients' outcome, especially with disease-free survival in all molecular subtypes, as we can see here as a result of these 2 multi-center pool studies. Now, moving on to the pathologic predictors of residual disease post-chemotherapy. We now know and can predict whether or not patient will achieve PCR depending on different breast cancer molecular and histologic subtypes. As we can see here in this table, based on multi-center pooled study, higher PCR rates are consistently seen among patients with HER2 positive and triple negative breast cancer, while hormone positive cases are relatively chemo-resistant, and especially those of invasive lobular carcinoma morphology. Data from our breast pathology registry here in Bahia, with the help of our data analysis engineer, Anwar El-Khalas, our data showed that out of 1620 excised specimens at Bahia Center who received neoadjuvant chemotherapy, high PCR rate was achieved in triple-negative breast cancer and also in HER2-positive cases, while luminal cases achieved only 7% of PCR. Another group of patients was also identified in our study, those with low ER and low PR status. They were found to behave like triple-negative breast cancer and achieve a similar rate of therapy, complete therapy response. In line with our finding, current evidence suggests that ER-low breast cancer cases has a similar outcome to ER-negative than to ER-positive in terms of disease-free survival and overall survival. ER-low expression also can predict chemotherapy effect. Studies also suggest that those patients could be treated similar to triple-negative breast cancer. There are also multiple potential biomarkers which can predict the effect PCR status. The main biomarkers are gene mutation, DNA methylation, circulating tumor DNA, and expression, gene expression panel like Oncotype DX, MammaPrint, and EndoProtect. These molecules can be identified in both tumor tissue and biofluids. Of these biomarkers, BRCA1 and BRCA2 gene mutation will be of our interest today. The rate of BRCA1 and 2 mutation is seen in up to 20% of triple-negative breast cancer, which is higher than in other subtypes of breast cancer. Several studies confirmed that BRCA status could strongly predict the efficacy of platinum-based chemotherapy, hence the achievement of PCR. Moving to another type of predictive biomarkers, a number of proteins detected by immunohistochemistry act as biomarker of PCR in different molecular subtypes of breast cancer. An example is the Ki67 proliferation protein, which can predict systemic response to chemotherapy. High Ki expression in tumor before treatment is associated with high rate of PCR. The International Ki67 Working Group agreed on that Ki immunohistochemistry could be used in ER-positive early stage cases with favorable anatomic prognosis to withhold the chemotherapy if the results is below 5%, and to proceed for chemotherapy if it is above 30% without the need of more expensive gene expression assay like MammaPrint or Oncotype DX and so on. And for endocrine therapy, Ki-67 may have a value to switch from endocrine treatment into chemotherapy if the decline in Ki-67 is not sufficient to suggest benefit from endocrine therapy. On the other hand, the working group does not recommend the use of Ki-67 as a routine to direct care, such as to withhold the chemotherapy based on low Ki status from patients, especially those with poor anatomic prognosis. This is due to the absence of standardized visual scoring method till now. Our recent published research on Bahia patients documented that triple-negative breast cancer, absence of lymphovascular emboli, high tumor grade, and the Ki proliferation equal to or more than 36% were found to be predictors of PCR in our patients. Another important predictor of chemotherapy response is the tumor-infiltrating lymphocytes. Chemotherapy response can be predicted with the knowledge of cellular composition of different types of immune infiltration, such as CD8, FOXP3, and CD4. High level of T cells, especially CD8 subtype, is a predictive of higher rates of PCR. Tumors that contain more than 50% of tumor-infiltrating lymphocytes are defined as lymphocyte-predominant breast cancer, and this is a predictor of PCR achievement. What about the relation between PD-L1 expression and response to chemotherapy? PD-L1 expressed in the epithelium or stroma act as predictor for PCR achievement for patients receiving chemotherapy. It was reported that high expression of PD-1 or PD-L1 was associated with low PCR percentage and hence worse outcome. Conversely, Cerebelli and colleagues concluded that PD-L1 was not able to act as independent prognostic index in patients with triple-negative breast cancer. This discrepancy might be as a result of the different cutoff values used and the discordant PD-L1 evaluation method. So in conclusion, pathologic response to chemotherapy is a strong prognostic indicator and is used to guide patients' subsequent treatment. Pathologists need to be sure that the correct area of the specimen have been evaluated both macroscopically and microscopically, and this rely on the communication and the collaboration with radiologists and pre-therapy clinical assessment. Pathologic features of tumor pre-treatment, such as tumor grade, tumor histologic, and molecular subtypes, are associated with residual cancer burden post-chemotherapy. Immunohistochemical biomarkers like Ki, TILs, ER, PR, HER2, PD-L1 correlated with chemotherapy, chemosensitivity, and the combination of some biomarkers might provide higher clinical relevance. And thank you for your attention.
Thank you, Dr. Ghada, for this lectures. The next speaker will be Dr. Sharif Naguib, the Professor of Surgical Oncology, National Cancer Institute. We'll talk about surgical management of breast cancer in the era of neoadjuvant chemotherapy.
Good morning, dear colleagues. I would like to, first of all, congratulate all people working in Bahia Breast Center because of the beautiful work they are doing for the Egyptian women. I would also like to thank the organizing committee of this conference, especially Professor Dr. Maher Hassan, for inviting me over to give this talk. I will be presenting what we surgeons think about neoadjuvant chemotherapy. So the talk's name is called Neoadjuvant Chemotherapy from a Surgeon's Point of View. Now, the most important purpose of neoadjuvant chemotherapy as far as the surgeon is concerned is to downstage the breast tumors, leading to improved chances of resecting tumors that were originally irresectable, and to provide breast conserving surgery to cases that were originally doomed to have mastectomy. It could also decrease the size of the tumor, so decrease the need for complicated reconstruction procedures, and accordingly decrease surgical morbidity. It will also allow the surgeon to do genetic testing like BRCA for the patient, and this will change sometimes the surgical decision-making concerning treatment of the patient. Neoadjuvant chemotherapy can also downstage the axillary lymph nodes, allowing the surgeon to preserve the axilla. Now, the indications of neoadjuvant chemotherapy, as far as the surgeon is concerned, are usually patients who will necessarily receive adjuvant chemotherapy in the old times, like locally advanced breast cancer, inflammatory breast cancer, HER2 positive, triple negative, or pathologically proven node positive axilla. These patients will receive adjuvant chemotherapy post-operatively, so why not try to give it pre-operatively and maybe succeed in downstaging the tumor, and so decreasing the scope of the surgical procedure. Neoadjuvant chemotherapy has some contraindications. I will not give it to tumors that are less than 1 centimeter with negative nodes. I will not give it to pure DCIS. I will not give it to patients who have like squamous metaplasia, for example, or if there are medical contraindications to chemotherapy. Please, and this is directed to surgeons, don't forget to mark the tumor with a metal clip before you start neoadjuvant chemotherapy, especially if you're planning for breast conserving surgery post-neoadjuvant, because sometimes the patient might lose her breast because we forgot to put this clip. Also, metastatic workup is advised only in stage 3 or higher, not in all cases. We do this metastatic workup by different types of CTs or by PET-CT. Now, the surgical decision-making by the surgeon in the setting of an MDT should be based on 5 factors. The patient's choice is the first one, and it should not be neglected. Sometimes some patients will ask for mastectomy. Her wish should be respected. Type and extent of disease and results of genetic testing would maybe direct the surgeon to do a mastectomy for the patient, whatever the result of neoadjuvant chemotherapy. Like, for example, in a BRCA positive patient, or if the disease was multicentric at the beginning, or in cases of inflammatory breast cancer. Whatever the result of neoadjuvant chemotherapy, mastectomy will still be indicated. The surgeon should also ask the clinical oncologist about the need for post-operative radiotherapy, because this will probably change the decision for reconstruction, whether autologous or implant reconstruction, whether immediate or delayed reconstruction. This decision will be based on the need for post-operative radiotherapy after surgery. And of course, the most important is the type of response to neoadjuvant chemotherapy will decide what surgical procedure is required. Now, there are many types of responses to neoadjuvant chemotherapy. There is a partial response in some patients. which is defined as at least 30% decrease in the size of the tumor, and there is a complete response. Now, partial response will help surgeons to provide breast-conserving surgery to patients who would originally have been treated or should have been treated by mastectomy. And this occurs in about 1/4 of patients requiring mastectomy at presentation. We see this partial response in more than 40% of triple-negative and HER2-positive patients. Now, there are two types of partial response, and my pathologist colleague just talked about it a few minutes ago. There is a concentric tumor shrinkage type, where the tumors becomes smaller all around, and we see this type of response more often with triple-negative and HER2-positive patients. And this is the type of response that we surgeons prefer because it allows us to decrease the resection size. The other type of partial response is the scattergun or shotgun or honeycomb response. And in this type of response, the tumor becomes fragmented, and we see this type of response more often with luminal type. And this type of response, we surgeons don't really like very much because finding the exact size of the tumor to be resected is difficult, and defining a good negative safety margin is sometimes difficult. Since we're talking about breast conservation, we should know that the safety margin after neoadjuvant chemotherapy is not different from safety margin without neoadjuvant chemotherapy. It is still no ink on tumor, even with adverse biology. This is a notorious paper that was published in the Lancet Oncology in 2018, and it is a meta-analysis that reported that patients who receive neoadjuvant chemotherapy have a much higher local recurrence rate than patients who do not. And it was shown to be higher by almost 5.5% than patients who did not receive neoadjuvant chemotherapy. Nevertheless, this publication has been criticized by many authors, and I can be happy to show you the latest NCCN guidelines that criticized this publication and concluded that it shouldn't be taken into consideration because out of the 17 trials that were included in this meta-analysis, most of them used non-standard chemotherapy regimens and used non-standard locoregional treatments and did not include target therapies and did not use modern imaging techniques. Now, what about the safety, the surgical safety of reconstruction post-neoadjuvant chemotherapy? Since now it is, reconstruction is used in most of the patients, like oncoplastic surgery or complete reconstruction of mastectomized patients. And it was found that the rate of complications did not increase after neoadjuvant chemotherapy. So reconstruction is still safe after neoadjuvant chemo. And this finding was confirmed by another publication that shows that even immediate breast reconstruction was still safe after neoadjuvant chemotherapy and did not delay adjuvant treatment. Now, what about? And it was found that overall and disease-free survival were not affected by neoadjuvant chemotherapy, and that it was oncologically safe even with breast reconstruction. And the same finding was confirmed in 2021 by the Korean Breast Cancer Society. The other type of response to neoadjuvant chemotherapy is the complete response. And this complete response is nowadays seen mostly in HER2-positive patients, where it could reach 70% thanks to dual blockade, where Perjeta or pertuzumab is added to trastuzumab. and up to 80% in cases of triple-negative breast cancer due to introduction of carboplatin in neoadjuvant treatment of these triple-negative patients. It is seen very rarely in hormone receptor-positive and HER2-negative patients. And the bright side of it, of pathological complete response, is that it is an indicator for improved survival. As you can see here, this publication by Cortazar showed that event-free and overall survival were higher in patients who showed pathological complete response when compared to patients who did not. Now, there is a fashion nowadays which is called de-escalation. There is a lot of talk of avoiding surgery in most of the patients. So some authorities tried to use MRI to predict pathological complete response instead of using surgery. Nevertheless, this publication in the Journal of Surgical Oncology in 2019 showed that MRI could not replace surgery to confirm pathological complete response. MRI accuracy rate was less than 80%, and 27% of the patients who showed no evidence of disease on MRI proved to have residual disease after surgical excision. So MRI cannot replace surgery to confirm PCR. Same thing was found about ultrasound-guided core biopsies, and this is the result of the MICRA trial that was undertaken in the Netherlands, and that concluded that ultrasound core biopsies could not replace surgery to prove PCR. Not only the MICRA trial, but these are multiple other trials in the MD Anderson, in German trial, University of Heidelberg, University of Birmingham, Seoul, the Royal Marsden Hospital in London, that all tried to evaluate ultrasound-guided core biopsies and try to replace surgery using these biopsies, but still they found very high false negative rates ranging from 5% to 50%. So core biopsy cannot replace surgery to confirm PCR. Now, what about the axilla? Neoadjuvant chemotherapy, of course, changed the approach of the surgeons to the axillary lymph nodes. And we had many question marks that appeared and that needed answers. Now, with neoadjuvant chemotherapy, if a patient starts as node positive before treatment and turns into node negative, is sentinel lymph node biopsy still applicable? The answer is not really, because of a high false negative rate, which may go up to 15%. But this changed recently, and the false negative rate could be brought down to less than 10%, which is the acceptable rate, by 3 studies: the Sentina trial, the American College of Surgeons Z1071, and the SN-FNAC study, which could bring down the false negative rate to less than 10%, which is acceptable, by doing 2 things. The first thing is to retrieve 3 or more axillary lymph nodes during the sentinel node biopsy procedure, or to use dual marker like methylene blue with radioactive colloid. Now, Donker in 2015 could bring down the false negative rate to 7% by using the MARI procedure, which is marking axillary lymph nodes with radioiodine seed. And he did not do any sentinel node biopsy with removing the marked lymph nodes. But when sentinel node biopsy procedure was added to removal of the marked lymph node, as Codell did in 2016, the false negative rate could be brought down to less than 1.5%, which is, of course, the best we could do. Now, another question that arose was micrometastasis in the axillary, in the sentinel lymph node. If the sentinel lymph node has micrometastasis, should it be considered as a positive node and proceed to axillary dissection, or should it be considered as a negative node as in patients who go for primary surgery? Actually, it was found that micrometastasis in the sentinel node is an indicator for axillary lymph node dissection, just like macrometastases. And why is that? That's because it was found that the incidence of other positive lymph nodes in the axilla with the presence of a micrometastatic lymph node after neoadjuvant chemotherapy was as high as 64%, which is the same rate as with macrometastasis. Now going back to de-escalation, can we apply the Z11 concept in the setting of neoadjuvant chemotherapy? Meaning that if we found a positive sentinel node, can we omit axillary dissection in select patients? Actually, not yet. It is not in the guidelines. And Armando Giuliano himself, who is the instigator of the Z11 concept, in a publication in 2017, concluded that in patients who have a positive sentinel node after neoadjuvant chemotherapy, axillary dissection is the treatment of choice. There was a trial called the Amaros trial, which tried to replace axillary dissection by radiotherapy in cases of positive sentinel nodes. Now, can we apply the same concept after neoadjuvant chemotherapy? Well, there is an ongoing trial called the Alliance 011-202, which is still ongoing, and we are expecting the results next year. So we don't have an answer to this yet. And the last question is if imaging or needle biopsy from the residual axillary nodes can replace sentinel node biopsy after neoadjuvant chemotherapy. And many trials tried to do that, but it was found that imaging, whether ultrasound, MRI, or PET-CT, and core or fine needle biopsy from the axillary nodes could not replace sentinel node biopsy to confirm complete response in the axilla to neoadjuvant chemotherapy. So we have a few messages to give to the surgeons concerning neoadjuvant chemotherapy. The first of which is, please don't forget to mark the tumor, and if the lymph nodes are suspicious, the lymph nodes should also be marked by a clip or by any means, especially if breast conserving surgery is planned after neoadjuvant chemotherapy. Also, mastectomy still has a role after neoadjuvant chemotherapy, and it is still done in about 1/3 of the patients with or without reconstruction. And in mastectomized patients who need reconstruction, we can do it safely after neoadjuvant chemotherapy, and this was found not to delay the adjuvant treatment. Now, in patients who are node positive before treatment and turn into node negative after neoadjuvant chemotherapy, sentinel node biopsy is reliable on condition we take 3 or more sentinel nodes, or we can use dual mapping, or we can remove lymph nodes that were marked before the start of neoadjuvant chemotherapy. And the 3 of these methods, all of them will decrease false negative rates. Now, going back to the de-escalation issue, we still cannot apply de-escalation after neoadjuvant chemotherapy to sentinel nodes because the Z11 concept cannot be applied after neoadjuvant chemotherapy, and replacing axillary dissection by axillary radiation after neoadjuvant chemotherapy still is not in the guidelines. And the final thing is in the axillary nodes or in the breast, can image-guided needle biopsy confirm PCR and replace surgery? And please keep in mind that surgery still has a role, and image-guided needle biopsy still cannot replace whether biopsies from the tumor bed or sentinel node biopsy. And I thank you very much for your attention.
Okay. Bismillah ar-Rahman ar-Rahim, Mr. Chairman. dear colleagues. First, I'd like to thank the organizing committee, Dr. Amani, and the rest of the organizing committee for giving me the opportunity. It's my pleasure and honor, and as per the title given to me by Professor Amani, we'll be talking about a very specific point, how to design the post-neoadjuvant therapy for patients, and this is a little bit of a complex issue. Now, unfortunately, we still have a significant health problem because of the health burden after even neoadjuvant chemotherapy, as already Dr. Shrif and the others have shown that we still have a problem in patients even if they achieve complete pathological CR. So we don't have 100% cure rate even in the complete pathological response. So the concept of post-neoadjuvant therapy constitutes a great opportunity for individualized cancer treatment, potentially improving outcome. This is something that you should understand very well so you can customize the treatment accordingly. Among the benefits of the neoadjuvant chemotherapy or neoadjuvant systemic therapy, which is very well known to you, I will put also, most importantly, within the red circle, providing an opportunity to adjust adjuvant treatment depending on neoadjuvant outcome. This is a very important part, apart from the other benefits. And as you can see from the pooled analysis by Cortazar, already mentioned, which is more than 12,000 patients, and this is the combined analysis showing that the event-free survival by achieving PCR is much better and significantly better than the patient who did not achieve PCR with a hazard ratio of 0.48, which means 52% improvement. More and above, it's already been there in the NCCN guidelines and in the St. consensus, and actually it's moving towards earlier disease. This is the HER2, for instance, and we're talking about any patients with node positive or tumor 2 centimeters or above. In the most recent NCCN guidelines, it went down to 1 centimeter. You are justified to use neoadjuvant therapy in HER2 in 1 centimeter tumor, as it's already there for the triple negative disease. There is an argument between tumors less than 1 centimeter or not. And this is one of the strongest statements in the medical literature about not giving patients neoadjuvant therapy, especially in triple negative breast cancer. It would not be ethical, which is extremely important. Okay, I guess this is a very important lesson to all us as oncologists, whether surgeons or medical radiation oncologists. You have to understand exactly and know what kind of definition you are following in complete pathological response. Complete pathological response differed through the time, but most importantly, what's agreed upon right now is disappearance of all invasive component in the primary and in the nodes. Early on, in the very early data at MD Anderson, they looked only at the tumor, which is not right. Now you have to look at the tumor and the nodes. And I'll leave it to every single one of you to accept the in situ component or not, but at least stick to the invasive component. There should not be any invasive component left in the tumor and in the nodes. The patients who achieve PCR after neoadjuvant chemotherapy have almost a 64% death risk reduction. And does it mean the same in all subtypes? No, it's different. And as you can see, the strong prognostic role of complete pathological response is the highest in the middle, 92% in the HER2 positive tumor. And this is the magnitude of the meaning of PCR. And it's about 84% in triple negative and the lowest 71 in the luminal subtype. So you really have to look into PCR and appreciate the tumor subtype you're dealing with. This is one. More and above, residual cancer burden is another very important factor that would determine the design of the post-neoadjuvant therapy you are talking about, in addition to other factors like the tumor-infiltrating lymphocytes and other genetic alterations. These are all predictors of recurrence, even in patients who did achieve complete pathological response. But with the two other factors, with the patients who did not achieve, this means a lot. Adding the Ki-67, which is a very important proliferative index, would add to the your decision to add or not to add, and what type of treatment you should add post-neoadjuvant therapy. And most recently, we are following the so-called composite risk scores. It's not only the clinical pathological features that come out of the pathology reports and the data we got from the surgeon. It's more or less an addition to the molecular findings. That's what we call clinical stage and the tumor biology. And you have to combine both, hopefully to get a composite risk scores. This is another very important form, especially for the luminal type, called the PEPI score. The PEPI score is another algorithm for scoring the tumor characteristics after neoadjuvant hormonal therapy in the luminal subtype. I mean, it's not that easy to follow, but it includes certain factors like the tumor size, the nodal status, the ER status, and the Ki-67 levels. More and above, in the era of trying to tailor treatment individually to every single patient. You have to appreciate the circulating tumor cells, the circulating tumor tDNA. These are all factors that might get into your decision to add on a certain type of treatment or not. I mean, like, if you don't find circulating tumor cells or ctDNA is negative, this might be a less option for you to add systemic therapy. We follow 3 different strategies in adding treatment to patients post-neoadjuvant. Number 1 is to add new medications or new substances, new regimens, or to intensify or de-intensify the type of treatment you were applying early on. I do remember in this setting, actually, and this is, if I may say, a personal experience. Early on in the late 90s, I was at King Faisal at that time in Riyadh. We did practice neoadjuvant extensively, and at that time, the standard chemotherapy regimen was FAC. Taxanes was very new. And anyway, and what we did was some sort of what we're doing right now, not exactly, is that patients who do not achieve complete response to FAC will receive Taxol thereafter, and vice versa. And we did present that in San Antonio in 1997. In terms of the data we have for the post-neoadjuvant treatment, we have more than one trial, namely the CREAT-X, the XTENET, the Catherine trial, and the Penelope-B. And the last but not least is the Olympia trial. And all of these are mainly directed to patients with subpopulations or subtypes of breast cancer, namely ER positive, HER2 positive, and triple negative disease. And what's ongoing is, most importantly, nowadays we are talking about the antibody drug conjugate. And you can see there's 2 important trials ongoing right now, and we should be waiting for the data coming out of these trials. We go by the HER2, which is the most actually treated by neoadjuvant chemotherapy or targeted therapy. We have the Catherine trial. The Catherine trial tested the following. Patients are treated in the neoadjuvant fashion, the usual chemotherapy with the trastuzumab, pertuzumab, and those patients who do not achieve complete pathological response are randomized to receive either TDM1 or no TDM1. And the data speaks on its own in terms of invasive disease-free survival. It's very important that the patient receive TDM1 in this setting. They have a much better outcome. And this is also very relevant in the subgroup analysis of those patients, as you can see in slide 1 and slide 2. Again, in the distant recurrence. So TDM1 did make a difference in those patients not achieving complete pathological response after having chemo and 2 anti-HER2 therapies in the neoadjuvant setting. Again, there is a marginal benefit in terms of overall survival. But most importantly, which is something that we all face in the clinic, which is a dilemma. I mean, the guidelines are changing right now. I mean, we did have the ER, PR, HER2, Ki67 before doing the surgery by the true cut. And most guidelines, especially in the US, did not call for repeating the markers after the surgery. But right now, it's not the case. You have to look into that because there are some decisions that might change. But this is one very important issue that we face in the clinic. You have a patient with HER2 positive disease to start with. You gave a very good treatment. You did the surgery. And when the pathologist came and you ask her or ask him to do the immuno, he comes out with a HER2 negative. And the question now is, should I stop anti-HER2 therapy? The answer is no. And no, no, no. The HER2 specifically is a heterogeneous tumors. And you're not only directing your tumor to the primary tumor and the nodal area, you're directing your treatment to the micrometastatic disease that really makes the difference in the outcome of the patient. And that was proved by the Catherine trial. If you look at the upper part curve, which is the dotted blue lines, those are the patients who received TDM1 and are HER2 negative on retest. When they were retested after the surgery, they came out negative, but they're still benefiting the most of the addition of TDM1. So forget about if the tumor is HER2 positive and you did the FISH or the immunohistochemistry and it came out after post-neoadjuvant therapy as negative, that you stop anti-HER2 therapy. This is not right. Don't do that. Sorry. Okay, this is the Catherine trial actually showing the, just look at the lower part of the slide about the residual cancer burden. The best outcome would be if you come with a less residual cancer burden, and this is a very consistent finding in all post-neoadjuvant therapies. So that's why you should do your best at the neoadjuvant setting, especially in the triple negative. The triple negative, we are short of of choices, not like the luminal and the HER2. You mainly have only chemotherapy, apart from the new treatments of immunotherapy or so, which is very expensive. So you should do your best to tailor the treatment to get the best outcome, which is hopefully a complete pathological response. Now we come to the CreateX. CreateX is a Japanese trial that tested patients with triple negative mainly, and some 20% of the patients in the population was ER positive. And those patients who did not achieve complete pathological response post-neoadjuvant did receive 6 months of Xeloda, which is an oral chemotherapy, and the data was in favor of Xeloda. As you can see, patients who received Xeloda did better. And now this is in the guidelines. It's the standard of care for patients who did not achieve in triple negative complete pathological response to add on 6 months of capecitabine. Platinum or not, this is another question. But again and again, you can see that this is the slide you got me in. Okay, this is the subpopulation analysis of CreateX showing the benefit of adding Xeloda to those patients. But most importantly, the Japanese Society of Medical Oncology did look into again and again the residual cancer burden. As you can see, that the best outcome as per the hazard ratio in the patients who came out with the least residual cancer burden. So this is very important. Do your best in the neoadjuvant setting. Now we come to the new era of the adjuvant therapy, and one of the classical landmark trials is the so-called Keynote 522. The Keynote 522 is directed to patients with triple negative receiving neoadjuvant chemotherapy plus pembrolizumab, one of the anti-PD-1 immunotherapies that we have, or no pembrolizumab. In addition, it added on the very right-hand side 9 cycles of pembrolizumab on the adjuvant, in the adjuvant setting. And the study endpoints, mainly the PCR event-free survival, in addition, and actually the study met its primary endpoints. As you can see, the pembrolizumab did make the difference, or the Keytruda, in terms of event-free survival and PCR rates. And that was seen through different follow-up terms, as it was only reported first in ESMO 2020 and now in ESMO 2022, with a very consistent finding all through the time. And you can see there is a 14% improvement in instance of PCR as on the left-hand side. This is very important. This is more PCR. This is what I'm talking about for triple negative patients. Look for something to give you more PCR, because if you are left with no PCR in triple negative, you are in a very bad situation. It's not like HER2, it's not like ER positive tumors. You have more than one options. But in case of triple negative, you are short of choices. Even in the instance of distant recurrence, it was halved by the addition of pembrolizumab in those patients. This is actually was very consistent in patients with both positive or not positive and not negative, and the PD-L1 status in this neoadjuvant setting didn't make a difference whether PD-L1 positive or PD-L1 negative. The patient did benefit, not like in the metastatic setting in the study 355. And this is again event-free survival by PCR. It's very important to mention, even the patients who did not achieve complete pathological CR by addition of pembrolizumab did better than the patients who did not achieve PCR and did not achieve pembrolizumab. Just look at the lower part of the slide. Forget about the PCRs, the upper ones, the green one and the red one. Even the patients who did not achieve complete pathological response had a much better event-free survival and significant 67.4 versus 56, almost 12 or 11% difference. This is a very important finding. So insist to follow those guidelines. This is actually by the hazard ratio, 0.73 in the PCRs and 0.7 in the non-PCRs, so it's more or less very consistent. Distant progression or distant recurrence-free survival is there with a 7% improvement and a very good hazard ratio, almost 39% improvement. Okay? The same as for the CreateX and for the other trials, look by the residual cancer burden. The residual cancer burden is best in the patients who have less residual cancer burden. For all of the above, it was already approved in the neoadjuvant setting and in the adjuvant setting. And nowadays, this is the slide. When you have a residual cancer, you know that we have 4 grades for the residual cancer burden, 0, 1, 2, 3. So if you have 2, you have a significant improvement by adding pembrolizumab. 76% versus 56%, as opposed to have marked residual cancer burden free, you don't really do a good job, though there is a 6% difference. So, yeah, this is also, you can see, as per the hazard ratio, the residual cancer burden 2, they do the best. And I'm sorry I'm moving fast because I know the time was delayed. So among patients with residual disease at surgery, there was a lower percentage of patients in each residual cancer burden category in the Pembro group than in the placebo group. And the addition of Pembro resulted in fewer event-free survival in residual cancer burden 0, 1, and 2. And taken together, these results indicate that event-free survival benefit from Pembro extends to patients who do not even achieve PCR. This is a very important finding. And last but not least is the Olympia trial, with now in the era of the PARP inhibitor. This is the design of the trial, and now they included the genomic composite risk categorization, not only the clinical pathological features, and they did randomize the patients who did not achieve complete pathological response to olaparib or no olaparib. And you can see in terms of invasive disease-free survival, the benefit was there with a significant improvement, almost 42% for the addition of a PARP inhibitor versus no olaparib. And this is very consistent in the subgroup analysis, as you can see that. Overall survival was marginally superior, however, was not significant for OLA versus not. And again, looking into the residual cancer burden, you see on the right-hand side that the best outcome with the minimal residual cancer burden. The more residual cancer burden post-neoadjuvant, the worst is the prognosis. So, just coming back to the first slide about neoadjuvant, because unfortunately, there are still some of us, I would not say surgeon, but maybe medical oncologists also, that are not very much convinced by neoadjuvant therapy. Neoadjuvant therapy is a very important type of treatment. It's an open eye treatment rather than a blind treatment, which is the adjuvant therapy. And this statement is a new one. However, it's a very old one by Ortobagi, the head of the MD Anderson. He said, if a patient is a candidate for systemic chemotherapy, and I know that she will receive systemic chemotherapy in the adjuvant setting, I will give it neoadjuvantly. This is a very clear message. I hope that we really understand that. And this coming statement will sometimes upset our surgeon colleagues, and with due respect to all of them and all of they do, that we don't have a scientific rationale to start with surgery unless there is a specific subtype. We started with surgery by habit because surgery was there before chemotherapy and targeted therapy and radiotherapy. But I mean, to design the treatment, nowadays we have to have an MDT. The surgeon, the radiation, the medical oncologist, radiologist, and pathologist should all sit together and look for the best of this patient, whether to receive preoperative treatment or to start with surgery. This is extremely important, and I'm talking to that about our young generation. So interdisciplinary network is very important. Looking into the principle of minimal residual disease, again, is very important in designing post-neoadjuvant therapy. Among all the facilities involved in the treatment of breast cancer patients, I would say that pathologists come first in the post-neoadjuvant area. They are extremely important. Defining the residual tumor accurately enough with all the characteristics of that residual tumor is very important and very helpful to the treating oncologist. That's why we call it now a theragnostic marker, which is a therapeutic and a diagnostic marker. And this is mainly already there by the pathologist. Pathology is extremely important. One of the most important also thing that the pathologists would tell us, the so-called isolated tumor cells post-neoadjuvant, this is not exactly the same as the diagnosis of isolated tumor cells you find in the nodes when you don't give neoadjuvant, because this is different. Those are very dangerous tumor cells that's left. Those are left after the application of the treatment, not the isolated tumor cells that received no treatment and they are still there. So you should look to them completely different. How to measure, what to measure, there are more than 18 different ways. And I believe that our pathologists in their community should standardize that and tell us exactly what kind of system they are using, and then we should follow their work. You can follow the MD Anderson computer algorithm to put the risk factors of the patient and come up with a scoring system that would tell you what kind of risk is this patient, like this type of composite prognostic score that includes more than one factor as per the MD Anderson Cancer Center. These are all very basic things that we always almost look for, and we ask our pathologists to help us with. I already spoken about the retesting of the tumor characteristics post-operatively, and you should look into the magnitude of benefit that you get from that retesting. And if you are fond of algorithms like our junior colleagues, this is one very important algorithm that you can follow in the different subtypes. ممكن طب السلايد الأخرانية بس اللي فيها الصورة لو سمحت. Okay, this is the take-home message, more or less the same. أنا كنت بس عايز أحط السلايد دي. Thank you so much.
اتفضل. Okay, thank you, dear professors, for giving us the chance to present this case today. We have an interesting case. We'd like for your opinion on it. Okay, neoadjuvant therapy of breast cancer, challenging case discussion. It's presented by Dr. Amira Dia, Dr. Amira Radwan, Dr. Muhammad Gamal, Dr. Mona Mamdouh. First of all, for any management of any breast cancer, we have to start with the history, radiological features, the histopathological features, the treatment, and all are discussed in the MDT. Our case today is MG, is 62 years married with 2 offsprings. She's a smoker, about 1 pack per day. She has a performance status score 1. She has a positive family history regarding her aunt. She's hypertensive, history of glaucoma and stroke. She underwent hysterectomy back in 2018 for a benign pathology. She came first presented to us with an accidentally discovered left breast mass. Clinically, there was a left lower inner quadrant mass, 4 by 4 centimeters, with overlying skin changes involving the inframammary fold. Also, there is a mass in the right lower inner quadrant, 2 by 2 centimeters, which was hardly palpable. We did some investigations. Dr. Amira Radwan will speak.
The patient was routinely imaged by mammogram and ultrasound. Let's see the imaging features. This is the right breast mammogram. We can see on the CC and MLO pictures of the breast, there are ill-defined, regular, equal density or dense lesions that are partially obscured, and there is one significant mass that we can all see, but also there were a few other surrounding suspected lesions. On the left mammogram, the clinically palpable mass, the one in question, was very obvious. It is, we can say this is one of the well-defined lesions that we encounter sometimes, and it shows a few edge spicules, but other than the fine speculations, the mass is very well defined. This is the ultrasound of the right breast, where it shows the suspicious mass as typically speculated hypoechoic with desmoplastic reaction. And this is a typical presentation of a malignant mass. The large mass in the left breast is seen as a heterogeneously hypoechoic rounded mass, and still, although it's very defined on ultrasound and mammogram, it is still a very suspicious mass. It's heterogeneous, and it showed, it doesn't show in this image, but it showed the suspicious vascular uptake. So we proceeded to the contrast-enhanced mammography to assess the multiplicity of the lesions, hence they are bilateral. On the contrast enhanced mammography, we can see the index mass showing contrast uptake intense in comparison to the low background parenchymal enhancement. And on the left breast, the mass shows very suspicious heterogeneous uptake. An MRI was done, and it revealed its superior ability to detect the multiplicity. As we see on the right side, it's not just one mass, it proved to be multiple central masses. So we proceeded to the ultrasound-guided biopsy, with Dr. Ramona will tell us the result.
Ultrasound-guided core biopsy was taken from the bilateral breast masses. Core biopsy from right breast revealed invasive duct carcinoma grade 2. ER was positive, showed strong nuclear reaction in 95% of tumor cells, scored as 8/8. And BR was positive, showed intermediate nuclear reaction in 30% of tumor cells, scored as 5/8, while HER2 was negative, score 0. Core biopsy taken from left breast revealed invasive duct carcinoma, grade 3. ER was negative, scored as 0 out of 8, and BR was positive, showed weak nuclear reaction in 8% of tumor cells, scored as 3 out of 8. And HER2 was negative, score 0. Hence, core biopsy from the bilateral breast masses revealed synchronous bilateral breast carcinoma. What's meant by synchronous bilateral breast carcinoma? Bilateral breast carcinoma could be synchronous or metachronous disease. Different reported time intervals have been used for a diagnosis of synchronous bilateral breast carcinoma, with cutoffs ranging from within 3 to 12 months between the diagnosis of the first tumor and the contralateral one. Whereas metachronous bilateral breast carcinoma are diagnosed during long-term follow-up. Synchronous bilateral breast carcinoma almost tends to have concordant tumor type, grade, hormone receptor status, and HER2 status. Substantial differences may exist between the bilateral tumors in individual cases. Heterogeneity in these parameters alters the therapeutic management. Prognosis seems to be dependent on the tumor with the worst pathological features. Our studied case revealed discordance regarding tumor grade and hormone profile. As we see, right breast carcinoma was invasive duct carcinoma grade 2, ER positive, BR positive, HER2 negative, which is luminal E. While left breast carcinoma was invasive duct carcinoma grade 3, ER negative, BR positive, HER2 negative, but which molecular subtype? This is the molecular classification of breast cancer. What is the subtype of ER negative, BR positive breast carcinoma, which are not included in this classification? ER negative, BR positive breast carcinoma accounts for 1% of all breast cancer. Several studies have found that the ER negative, BR positive phenotype may represent a distinct subtype. ER negative, BR positive breast tumors have different tumor and patient characteristics compared to both ER positive, BR positive, and ER negative, BR negative ones.
So in order to sum up the case, this is a lady with bilateral synchronous breast cancer with discordant subtype. On the right side, it was a T4 mass, and on the left side, it was multicentric. NDT was discussed, and we agreed to have a neoadjuvant chemotherapy followed by bilateral mastectomy. But before we proceed to chemotherapy, would you like to add another investigation for these patients? Yes, according to the recent NCCN guidelines, we have a lady with bilateral breast cancer with a positive family history, and with the one side of them is almost triple negative, and hence BRCA1 testing should be done in this lady. But unfortunately, we cannot do it. Then, what is the best neoadjuvant? I will not discuss all the types of neoadjuvant because my professor, Dr. Heba and Dr. Ala Andil, have thoroughly discussed the issue of neoadjuvant regimen. But I just want to highlight that on one side it's luminal, and on the other side it's almost triple negative. And hence we decided to give her the routine neoadjuvant, which is an anthracycline-containing regimen with taxanes. The patient received the neoadjuvant chemotherapy, and clinically there was no palpable lesion in both breasts. Hence, the luminal achieved a clinical response, and the triple negative on the other side also achieved a clinical response. The patient was referred for surgical review.
So after she was referred to surgical review, the question was, would you recommend imaging before mastectomy in such case? Well, the patient had initially bilateral breast cancer, locally advanced on the left side and multicentric on the right side. So there was no benefit of post-chemotherapy imaging, and the decision would be the same, which is a bilateral sample mastectomy. So the patient underwent bilateral sample mastectomy and sentinel lymph node biopsy. The drains were removed after 2 weeks. It was complicated by a small dehiscent wound on the right side, which was managed by secondary sutures. Maybe the smoking history has a role in it. And she had to come in multiple visits for seroma aspiration bilaterally. Then we referred the case back after histopathological features first.
Right simple mastectomy post neoadjuvant chemotherapy revealed no residual viable tumor cells with complete therapy response. And right sentinel lymph node biopsy post neoadjuvant chemotherapy was negative for metastasis, 0 out of 4 with no therapy effect. While left sample mastectomy post neoadjuvant chemotherapy revealed residual viability 5% and focal high grade DCIS. This is the invasive component, and this is the in situ component. Left sentinel lymph node biopsy post neoadjuvant chemotherapy was negative for metastasis, 0 out of 5 with no therapy effect. The calculated residual cancer burden class on right sample mastectomy was 0, while of the left one was class 1 with residual cancer burden index 1.32.
Coming on to the adjuvant treatment, in order to emphasize what Dr. Ala have said, that adding on since there was a residual cancer burden 5% and a tumor viability of 5%, we started adjuvant treatment according to the CREATE-X trial, and managing the patient to having a triple negative disease with residual burden and viability of tumor 5%, so the patient started adjuvant Deloda, followed by adjuvant hormonal treatment. And the patient is doing well now, alhamdulillah. This is on the case. Then she was referred to radiotherapy. Thank you. bilateral
هنفتح خلصتي يا دكتورة أمير؟ خلصتوا كده ولا ايه؟
دكتور هبة، ازاي حضرتك دكتور هبة؟ منورانا والله. الليفت سايد كان T4، كان في diffuse skin thickening initially قبل الكيموثيرابي، اللي ده السايد اللي كان تريبل نيجاتيف. الرايت سايد كان مالتي سنتريك باي ذا MRI، وهي كانت 65 years old. لا، كان في فوكس اكتر من 5 سم، ما كانتش تيجي، كان في فوساي بعيده. حتى كنا لو احنا كانت يونج ايج شويه كنا ممكن نفكر في ريكونستراكشن، كنا عملنا لها كونتراست بعد الكيموثيرابي، لكن هي حتى 65 وسموكر وكاردياك.
حضرتك هتقول حاجه؟
الريزيديوال كان كومبليت ريسبونس على اليومينال، كومبليت ريسبونس على اليومينال، لكن ريزيديوال على التريبل نيجاتيف.
يعني دكتورة أميرة طبعا أنت you raise very important question to do a BRCA mutation because يعني مش عذر طبعا ان احنا ما عندناش، احنا في معهد الاورام في BRCA mutation and we can sponsor here بدم انتوا برضو فهي you can sponsor حتى any private why I'm telling that لان الديسيجن ثانية واحدة حضرتك بعد اذنك كتر خيرك I'm telling that لان everybody talking about BRCA mutation in a young patient with a family history. But nowadays, in any triple negative, you have a recommendation to do BRCA mutation even at 70 years of age, because this will change the decision for surgery. يعني أنا بالعربي متضايقة وزعلانة إن ليه عملت bilateral mastectomy. لو if you do BRCA mutation and it's positive تقريبا هسكت، لأن ده هيكون السبب الوحيد إن أنا عملت كده. يعني مش هقول ان 65 سنه تستاهل بايلاترال ماستكتومي وال45 لا، لانك انت you saw yourself some patient with us 80 years and still we discuss here to doing mastectomy. يعني انا نفسي ببقى يعني بريست كونزرفيشن مش ليكي بس فاهمه قصدي؟ ف BRCA is very important على فكره، لازم نعلم نفسنا. It can help her in the neoadjuvant. It can help her in adjuvant and help her in decision to doing in the surgery. عايزه برضه اقول حته نفسيه شويه او انسانيه شويه. هو لما يبقوا بايلاترال الاسهل بايلاترال ماستكتومي ولا نحن ندو اور بيست ان وان سايد اند اور بيست ان ذا اذر سايد؟ يعني ما نستسهلش نقول ايه ما هي كده شايله لان في لسه البريست كونزرفيشن. يعني الاوت كام اوف 65 سنه لازم كواليتي اوف لايف تبقى كويسه، وهي فاجئتنا ودخلت في الباثولوجيكال سي ار وستيل الايف انت قلتي حضرتك من غير اي ايفنت، واخده بالك؟ فلازم نكمل بقى حته الكواليتي اوف لايف.
تسمحي لي اعلق يا دكتوره هبه؟ هو دلوقتي البراكا ميوتيشن تيستنج موجود في بهيه وبدانا نعمله فعلا للبيشنتس زي سام سيلكتد بيشنتس بس احنا بنعمله. الحاجه الثانيه في الام دي تي احيانا بيحصل يعني اوفرلوكينج على الايمجز، فبيبقى في فوكس مش باينه قوي جايز لكن بنشوفها، فعشان كده بنجو ثرو البايلاترال ماستكتومي. يعني هو مش عشان عيانه 65 years اخذت الديسيجن عشان تدخل البايلاترال ماستكتومي، هي فعلا كان عندها فوكس اواي فروم ذا برايمري، فبناخد زي ما تقولي حضرتك سكه السلامه يعني، فبنعملها ماستكتومي ذيس از يعني بيتر فور هير. بس
طيب دكتور عمرو حسام مدرس جراحه الاورام مركز اورام المنصوره. في وان سايد كان في سوليتاري تيومر واتشيفد كومبليت ريسبونس اللي هو الهاي جريد تيومر. فيعني خلينا من المالتي سنتريك سايد ده هنتكلم فيه بعد شويه، بس وات از ذا انديكيشن فور ماستكتومي على الجنب اللي فيه السوليتاري تيومر اللي حصل فيه كومبليت ريسبونس.
اللي حصل فيه كومبليت ريسبونس اللي هو اليمنى
سوليتاري تيومر،
مش هو ده اللي كان انا طبعا
احنا عندنا بايلاترال بريست كانسر وان سايد
ده كان تريبل نيجاتيف. كان في اعتقد انها كانت تي 4 سكين ايديما ممكن يكون
طيب.
ده.
يبقى احنا دلوقتي احنا السيرجيكال بلان according to the pre-treatment situation ولا according to the post-treatment situation؟
في حاجات بتبقى بري تريتمنت سيتويشن يشود جو فور.
لا خلاص
يعني
خلاص
انت لو
خلاص.
عندك عينه انفلاماتوري بريست كانسر،
لا انا بتعامل مع الحاله كسيرجن على البوست تريتمنت ستيتس.
ولو العينه انفلاماتوري هتعمل ايه؟
لا.
ولو العينه مالتي سنتريك هتعمل ايه؟
لا
هي
يا دكتوره ما تقوليش مالتي سنتريك وما تقوليش انفلاماتوري، خلينا في الحاله بتاعتي. جريد 3
هايل
كانت لوكالي ادفانسد، كان فيها سكين اديما، اديت التريتمنت بتاعي، التيومر ريجريسد، السكين اديما فكت.
انا مش هجاوب عن الجراحين لكن انا اي ثينك ذيس از فيري ستيل ديبيتابل بوينت.
لا ما عادتش ستيل، كانت ستيل ديبيتابل. انا كسيرجن انا بمانج الكيس
دكتور حمدي هيرد على حضرتك.
I think there is no wrongdoing treating this patient with bilateral mastectomy for different indications. The first one had a multicentric. Okay, you may counsel this patient for skin sparing and reconstruction after she had finished her treatment. But the other case was T4, and T4 we treated with mastectomy, and the decision is taken prior to starting chemotherapy and Herceptin and everything. And if she demanded reconstruction, it would be a delayed one. So again, there is no wrongdoing in doing a bilateral mastectomy in this patient.
طب اضافه بس، انا السايد اللي هو كان يوني فوكال وحصل فيه ريجريشن ده كان ممكن يعمل كونزرفاتيف. السايد المالتي سنتريك طبعا هو الديفينيشن بتاع مالتي فوكال ومالتي سنتريك اكيد الباثولوجيست بقى يعرف دلوقتي ان الترم ده بقى اولد ترم، بقى في حاجه اسمها مالتيبل ابسيلاترال بريست كارسينوماز، ده بيشمل المالتي فوكال والمالتي سنتريك. قصه المسافه 5 سم ما بين التو فوساي او ان الديفرنت كوادرانت دي خلاص دي بقت اولد ديفينيشنز. الديفينيشن دلوقتي اسمه مالتيبل ابسيلاترال بريست كارسينوماز. هل المالتيبل ابسيلاترال بريست كارسينوماز ده ابسوليوت كونترا انديكيشن للبريست كونزرفاتيف سيرجري؟ كان زمان ابسوليوت كونترا انديكيشن، انما الابديتس دلوقتي اذا انت قدرت تعمل كلير سيفتي مارجن وان انت تاتين اكسبتد كوزموتيك اوت كم وان انت تاخد الراديشن ثيرابي في الاوبتيمال تايم، فده مش كونتر انديكيشن خلاص للبريست كونزرفيشن في المالتي سنتريك. كلير مارجنز، اكسبتد كوزموتيك اوت كم، راديشن ثيرابي ان اوبتيمال تايم.
طيب بس احنا عندنا معلش يا حسام مشكله مهمه، انت ستيل يو هاف ريزيدوال ديزيز، يعني هو حتى بوست اوبراتيف لقى ريزيدوال تريبل نيجاتيف.
ما هو في جنب خلاص في كومبليت بي سي ار، وفي جنب اللي هو اللي لسه فيه ستيل ريزيدوال ديزيز.
لا اللي كان ريزيدوال في التريبل نيجاتيف، وعشان كده كان ده انديكيتد ان هو ياخد الكابسايتابين بالظبط.
هو انا ممكن اقول
ايوه
حاجه؟
هو الريزيدوال ديزيز ده انديكيشن للماستكتومي. هو الريزيدوال ديزيز انديكيشن للماستكتومي؟
لا انت فوجئت بعد ما عملت كمان الماستكتوم فيه ريزيدوال ديزيز.
ايوه ما هو كان ممكن الريزيدوال ديزيز ده يتشال بكونزرفيشن.
انت لو كنت عملت كونزرف فروم ذا ستارت.
طب انا ممكن اقول حاجه بس على الحاله دي. احنا على فكره الترند عشان حسن الكلام واخدنا مجرى ان احنا وانس مالتي سنتريك بنعمل ماستكتومي. لا احنا بيبقى قاعد معانا الجراح هو بيشوف دي فيزبل له انه يشيلها بكونزرفتيف حتى لو هي مالتي سنتريك او مالتي فوكال ديزيز او كده. فالجراح اللي قاعد معانا في التيومر بورد هو اللي بياخد القرار. وبيحصل ديسكشن بينهم وبين دكتور ماهر تاني، واحيانا بيرجعوا يراجعونا تاني في الحاله. فيعني القرار اللي اتخذ فيها على الرايت سايد كان بناء على عدم قدره الجراح ان هو يشيل المالتي
تمام.
بالنسبه بقى للليفت سايد اللي هي كانت تريبل نيجاتيف كان فيها ايديما بيرزيستنت بعد الكيموثيرابي.
طب ماشي، ما الكلام ده ما اتقالش بقى.
بس
لو الإديمة دي كانت ريزولفد اقدر اعمل كونزرفيشن.
أيوة
لو المالتي سنتريك ديزيز ده اقدر ان انا اشيله بسيفتي مارجن كلير، اقدر اعمل كونزرفيشن.
ما ده اللي انا عايزه افهمك.
النقط دي ما توضحتش بقى.
كل الكلام ده احنا بنبوت ان كونسيدريشن واحنا بناخد الديسيجن بتاع المانجمنت، وزي ما بقول لحضرتك ساعات بناخد الديسيجن ويرجع دكتور يتناقشوا.
شكرا يا دكتوره رشا.
او بعد ما يرجع يشوف العيانه.
شكرا يا دكتوره رشا.
شكرا يا دكتوره
رشا. شكرا جزيلا. احنا يا جماعه دلوقتي اوبن الدسكشن على السيشنز التوكس اللي احنا اللي كانت في السيشن دي. اول توك دكتوره هبه الظواهري وكان عنوانها important questions to be addressed for neoadjuvant in breast cancer. في حد عنده اي اسئله لدكتوره هبه على التوكس بتاعتها؟
دكتور علاء فين؟ دكتور علاء قنديل.
طيب اتفضلي يا فندم.
دكتور علاء فين؟
In your experience, Dr. Heba, you use carboplatin or platinum drugs for triple negative? In spite of you have no consensus till now or no proved guidelines, even at 2023 guidelines in NCCN? خلي حضرتك دكتورة هبة.
السؤال ان هل احنا نستخدم البلاتينم سولتس في كل حالات النيو ادجوفانت تريبل نيجاتيف؟ موست اوف ذيم يا دكتوره مها، واحنا في معهد الاورام بقالنا سنتين وي ابلايد بلاتينم ريجيمن ان ذا تريبل نيجاتيف مستندين على الجيرمان ترايل لانها كانت اكتر ترايل ماتيور، وبعد 9 سنين قالت ان addition of platinum versus no platinum even though without BRCA mutation and even though not in young patient and even without axillary infiltration also subset of patient behave better.
You get result for these 9 years to be a recommendation or guidelines?
أيوة. In the Europe platinum containing regimen in the ESMO and the medical oncology, School of Medical Oncology, rather than the ASCO. The ASCO still not for everybody, for patient selection and by BRCA mutation.
Okay, شكرا. Thank you.
بص حضرتك البرايتنس 3 ترايل كانت بتقيس البارب انهبيتور الفيليبارب مع الكاربوبلاتين تاكسين في التريبل نيجاتيف. الفيليبارب كبارب انهبيتور ملوش اي دور خالص، عشان كده it wasn't included in the neoadjuvant. However, الكاربوبلاتين if we extrapolate the data, platinum salts are very important. الترايل دي كانت فيز 3 2018 كان improved sorry. It is not it's not category 1 definitely
not
it's not category 1
بس
it is recommended as category 2A. يعني لان احنا I don't think ان حد هيفولو اب الكيموثيرابي على long run خصوصا في وجود التارجت الثيرابيز الجديده يعني.
شكرا دكتور احمد.
I have a question here. بعد اذنك دكتوره. انا برضو عندي I have a question دكتوره هبه ودكتور علاء لو موجود. I'm a radiologist. Sometimes I get confused about the implementation of neoadjuvant treatment in all types of cancer, regardless of anything. For example, هل مثلا luminal A type cancer 1 centimeter 1 to 2 centimeter node negative, will we go for a neoadjuvant treatment? This, for instance, because the message maybe I didn't quite understood, but you will give neoadjuvant treatment on all types of cancer, regardless. We need to clarify a little bit for the non-oncologists,
okay.
Just to understand this. Thank you.
Non-medical oncologist. سؤال حضرتك طبعا واضح جدا ومهم جدا، والدكتور اشرف سليم مش حضرتك ما فهمتش، حضرتك فاهم كويس جدا. and this is a very gray zone in the medical oncology in the neoadjuvant, and a lot of controversial issue in this very particular question. The era of the neoadjuvant extend itself like it's a standard of care for everybody, but it is not. In between brackets every time telling us that MDT must revise everything. Until we, now it's currently like a trend, like 80% of the patient will take neoadjuvant chemo. But in the era of very small tumor, in triple negative and HER2 positive, we can discuss many days. So this is a very controversial and it's gray. الأستاذ الدكتور علاء أنديل مشي لأنه عنده حاجة مهمة. هو he mentioned in triple negative even less than 1 centimeter or 1 centimeter, he recommend doing neoadjuvant. For me, it is not, and I can argue with him. So this is in triple negative and HER2, yes, it's 90% of cases will receive. لكن لو جت حاجة معلش عشان المجموعة كلها تركز، لو جت لنا حالة عندها 45 سنة أو 48 سنة وتريبل نيجاتيف وفيري اوبروبل وليمف نود مش affected in the axilla، أنا أول واحدة هقول نعمل سيرجري. sometimes by screening، يعني عيانة جاية بتعمل نفسها screening فتيومر is 1 plus or minus millimeter، برضو مش هنديلها نيو ادجوفنت، يعني في برضو هامش. in the luminal group of patients ديبيت كبير جدا. اليومنال ما بيستجيبوش بالكيمو لكن بيستجيبوا بالاندوكراينال تريتمنت. you have to be very patient، you have to be very patient، وده الارجيو بيننا وبين الجراحين. يعني اكني باخر الفرونت لاين تريتمنت which is surgery وبدي فرصه فو اندوكراينال ريسبونسفنس. هنا 50% ممكن يستجيب و50% ارجع لورا، يبقى خسرت وقت. يبقى ستيل اجين بوست مينوبوزال luminal borderline of probability endocrinal treatment. Premenopausal very small luminal عارفه ان مش هديلها كيمو، this is over treatment خلاص دلوقتي. يعني not because of age او premenopausal حد كيمو، this is very important. حد endocrinal treatment بس هستنى 6 شهور better to go to surgery.
اعتقد دكتوره هبه برضو الفاسيلتيز اللي موجوده عندنا في مصر ما نقدرش نعمل موليكولار وانكو تايب والحاجات اللي هي تفيد اليومينال، دي اهم حاجه
بالظبط.
once we diagnose اليومينال we have to go to molecular study والانكو تايب دي اكس. وده اللي بيحدد اللاين اوف تريتمنت.
ومهم جدا.
فاحنا دلوقتي بناخدها كده يعني اعتبارا، انما actually you have to do this facility.
بس كلام حضرتك يا دكتوره مها الزعفراني مهم جدا علشان كل يوم ما نزعلش. يعني ايه كل يوم ما نزعلش؟ يعني في حالات كتير اخر كل لجنه يا ريت نعمل اونكوتايب، يا ريت نعمل اونكوتايب. حديثا بعد الكلينيكال ترايلز ما بقت ماتيور الماندكت اند اكس ريسبوندر كده، قال لك this is not enough, genetic information is not enough and incorporate معاها الجريد والتيومر سايز والايدج والاي ار سنسيتيفيتي. يعني انا وانا قاعده في معهد الاورام عيانين ما اقدرش اعمل اونكوتايب، مش زعلانه بقى دلوقتي. I can predict by other method. اتفضل يا فندم.
Thank you دكتوره هبه for this explanation. I'm دكتور محمد العناني Azhar University. The very good question from our professor. The discrepancy in the opinion between Dr. Sharif and Dr. Ala even is different. Dr. Ala at the end concentrated on a certain point. What about the circulating tumor cells and circulating DNA? Text home message from both is different. If you can explain to us the difference between both.
Okay.
I hope. The second question, what is the final conclusion, final opinion in pathological complete remission? Pathological complete remission, what can we do with the patient, and how can we follow up this patient? Thank you.
شكرا يا فندم على السؤال. هو من كتر ما الناس دلوقتي بقت تدي نيو ادجوفنت فور everybody، بنفاجأ بان في ناس استجابت كويس جدا وفي ناس استجابت اقل جدا. فهاو تو بريدكت، اصبحت الترايلز مش بس استخدامات كيموثيرابي متعدده، لا عايزين حته بيزك او حته لابوراتوري تفيدنا. الناس بقى لها 10 سنين بتتكلم على الكي اي 67 and this is very important to show the level decreasing. When it is rapidly decreasing after 2 weeks, this is علامه كويسه جدا على فكره prognostic. If it is decreased at the end of the neoadjuvant which is 6 أو 8 cycles برضو علامة كويسة جدا. لدرجة ان يعني معلش دي مقدمة هقولها، لدرجة ان قسموا البيشنت according to disease free survival الى لو يعني كان لو فضل لو، ولا هاي and لو كان هاي وبقى لو in the neoadjuvant setting and say. خلصنا من الكي اي 67 as a predictor، رحنا على circulating tumor cell. From the early beginning on the tumor biopsy and not surgery, we do circulating DNA tumor circulating DNA fragments. And if it is increasing and then decreasing, again, this is a very good not only for disease-free survival and over survival, short time to have a metastasis. And this is again is very important. And nowadays we can do it in the liquid biopsy even. So this is very important for biobanking بقى. الناس اللي هتحتفظ كده. كل الدراسات من ايام الاتاك ترايل لو تفتكروها 25 سنه ما نجحتش الا لما عملت لنفسها biological markers that now projected after 25 years.
Do you mean by DNA fragments? Is a DNA ploidy, which is done by flow cytometry DNA analysis?
أيوه.
Or this is another method for DNA fragments?
لا أنا صراحة مش
The detection of
biologist.
DNA ploidy is by flow cytometric DNA analysis.
بالnext generation أيوه sequencing.
And is it available
في معهد
at your
الأورام؟
hospital?
أيوه طبعا. أنا أعتقد هي going now عندهم بايو بانكينج، لكن أنا شخصيا أشرفت على كذا رسالة في معهد الأورام. We are recognizing أو detecting a circulating tumor cell and see it as a prognostic and predictive factor.
But practically speaking, I didn't know any area, any place in our country
Circulating
can do
tumor
DNA
cell?
ploidy now.
لا
You
احنا
have
بنعملها في المعهد في القسم البيولوجي. ايوه.
Cancer Institute. Thank you.
شكرا يا دكتورة هبة على المناقشة الجميلة دي، وبنشكركم جميعا على الحضور السيشن، وإن شاء الله في بعد كده كامباني سيمبوزيوم سانوفي لو حضرتكم عايزين تحضروا.
These are my disclosures for today. So why breast cancer? So breast cancer is the superstar of oncology. Why? Because it's the highest incidence in females, and actually it is the highest incidence in mortality. So now we know why are we talking about breast cancer. So this is an important disease that we need to manage. And the problem with breast cancer is it presents with metastatic disease according to the age. According to this study published in 2015, shows us that there is a rising range of metastatic early presentation or upfront presentation in a young age of 45 to 64. And actually projected by 2030, it will increase markedly around, as I can remember the numbers, around 53% we're going to have upfront metastatic cases in young individuals. What about the docetaxel? Docetaxel is a chemotherapy. What is its function? Actually, it has a nice function, which stabilization of the microtubules. So instead of cutting the microtubules, it stabilizes the microtubules. So when the cells go into the M phase, it stops. Why? Because the DNA is not equally distributed in both cells. So both cells undergo apoptosis and die. And actually, if we looked at the cytotoxic activity in breast cancer cells, you will find that it is 2 to 4 times that of the paclitaxel. And actually, it demonstrates a synergistic effect when added to other chemotherapies. So by its own, it's very effective, maybe better than paclitaxel, and hold your thoughts for that. I'm going to show you the data. And when you add it to chemotherapy, other chemotherapies, we all know that we can combine chemotherapies in metastatic breast cancer for rapid control. It has a synergistic effect, meaning an added effect. And if you look at the FDA approval, it is approved, the docetaxel, or the trade name as Taxotere, as a single agent in treatment of metastatic cases, in combination with doxorubicin in metastatic cases, in combination with other chemotherapy, and so on. And if you look at a comparator arm, this was a meta-analysis comparing the docetaxel to other chemotherapeutic arms, you will find all through that you can find that the overall survival is better even if it's only by 1 month, but you can find a statistical overall survival. Although it was not superior in the overall response rate in comparison to paclitaxel, but if you look at the time to progression, survival time, and response duration, it was definitely statistically significant in comparison to the paclitaxel. And this is a randomized phase 3 trial adding the docetaxel to the anthracyclines like the doxorubicin and cyclophosphamide, and as known as the TAC regimen. In comparison to the AC, you can see the progression-free survival improvement with the beautiful separation of the curve, as you can see, with a statistical significance of 0.014. Again, if you randomize the docetaxel, again, if you look at the subgroup analysis or the forest plot, you will all see that it's in favor of the addition of the docetaxel, which improved the overall response rate in combination with the doxorubicin. Then we're all scared about the docetaxel and its side effects, right? We all are scared when we give the docetaxel, the patient will go for neutropenia and neutropenic fever. But then if you look at this randomized trial, adding the docetaxel with the growth factor receptors, you will find that, I mismatched, the trials. Here, if you add the docetaxel to the anti-HER2 targeted therapies, you will find that you get in the subgroup and the forest plot that all was in favor of the addition of docetaxel to the targeted therapy, the anti-HER2. Now we do have lots of formulations for the docetaxel, whether generics or the originator. So this was a study comparing the originator drug. It was published in 2008, comparing the originator drug to the generic drugs. And you can see here that the conclusion that the generic drugs have lower level of active ingredients of the docetaxel. This is to show you that this may potentially under-response the tumor itself to the docetaxel. So better to use the originator rather than the generics, because the concentration of the active ingredient, which is the docetaxel, is not as high as the originator. What about the neutropenic fever that I mentioned a few slides back? When we give the docetaxel, we all know that we get febrile neutropenia. Let's not say febrile neutropenia. How to prevent that is by primary prophylaxis using colony-stimulating factor. So if you add the colony-stimulating factor, you will find that the serious adverse events of neutropenia or neutropenic fever is going way down with the addition of GCSF. So the conclusion here is you have to prepare yourself for the upcoming side effects, which we cannot deny that, yes, you can find neutropenia, but if you predict it and use a primary prophylaxis, you can prevent your patient because you'll get a better overall response rate, time to progression, and overall survival. What about the toxicity? It's very important that you tailor the choice of treatment according to your patient. So if your patient has an elevated AST or transaminitis of more than 1.5 times, then please revise yourself before using the docetaxel because you might add to the toxicity. What about the alkaline phosphatase? And this was published by Drugs in 2004. If you have the alkaline phosphatase of more than upper limit normal, double the upper limit normal, then again reconsider using the docetaxel, whether the generic or the originator, before giving it to your patient, because this will add to the greater toxicity in the form of neutropenia, salt and water retention, or even third space loss. Then comes the dilemma of we're scared to use the docetaxel with elderly patients or frail patients. Although you get a better response shown by the meta-analysis I showed you, then why not get this response with our elderly patients? And we're all scared of using docetaxel with the elderly patients. So do we have a solution for that? Yes, actually we do have, because they compared the safety and efficacy of weekly docetaxel, and the ranges you will find in many trials ranging from 35 milligram per meter squared up to 50 milligram per meter squared weekly, and they found out that the response rate was equivalent and actually the toxicity was less. And this was proven also in another publication. This is a very old publication in 1998, but again, we're in the era of the novel and precision medicine, so you won't find a lot of data about chemotherapeutics. But however, increased age, the conclusion from this trial, that the increased age does not affect the docetaxel efficacy at all, and please use primary prophylaxis with GCSF. So to conclude my talk today, docetaxel is a microtubule stabilizer leading to arrest in M phase, and meta-analysis showed us better overall survival, time to progression, and response duration in comparison to the paclitaxel or other single-agent chemotherapies. Yes, it has a manageable toxicity profile. However, you must be prepared for this toxicity profile, and it can be used safely in elderly patients with the weekly regimen. Don't forget, at the end of the day, MDT, talk together to save your patients. We do have data showing that the MDT by itself improved the response and the overall survival of patients by 30% without even adding a single drug. And thank you so much for listening. Okay.
Thank you, Dr. Ahmed, for your elegant presentation. Now we have discussion with Professor Dr. Hiba.
تفضلي.
شكرا دكتور أحمد. Very excellent. طبعا you are talking about a little bit old subject.
Yes.
Very well known to everybody. يعني بما اننا قاعدين في قاعده برضو to revise all our standard, adjuvant docetaxel was a landmark in many trial, TAG versus FAC, and then docetaxel single agent, FAC treatment 3, and then docetaxel 300 per meter square as a single agent, in the adjuvant setting, and it is moved to the neoadjuvant to be very effective in breast cancer. يعني أنا عايزة أعرف إيه اللي حصل. أنا I revised طبعا the trial, and I see that the American side of the world recommend paclitaxel to be replaced in the adjuvant and the neoadjuvant setting, although there is still some European center using in the adjuvant FEC and then followed by docetaxel. سؤالي ليك تحديدا عشان انت شاطر وقارئ واحسن مننا كلنا.
دي شهاده يا فندم.
هل هناك يعني definite recommended evidence that we still use paclitaxel superior than docetaxel?
الكومباريزن احنا بنتكلم عن الميتاستاتيك، بس الكومباريزن كانت في النيو ادجوفنت حضرتك ان when they compared الدوسيتاكسل every 3 weeks with docetaxel weekly versus paclitaxel every 3 weeks, paclitaxel weekly, they found out that the best two regimens were the docetaxel every 3 weeks followed by الpaclitaxel weekly. الديفرنس الوحيد كان بينهم
This is the American studies, and the difference is very minor.
Very mild, وكان الفرق في الريكار
toxicity more than the response.
Definitely toxicity.
أنا مش عارفة إزاي في الإيرا دي، يعني ده سؤالي أنا عايزة أستريح. في إيرا كده من أكتر من 7 سنين أو 5 سنين بعد الترايل دي والاسكو ريكومنديشن تقريبا انسحب الدوسيتاكسيل من الادجوفنت النيو ادجوفنت. ام نوت توكينج ميتاستاتيك الحقيقه يعني.
okay.
انا ام توكينج ادجوفنت النيو ادجوفنت. عايزه اعرف انت قناعتك هل ستيل باكليتاكسيل السوبيريور؟
لا
هو كومنلي يوز انا اي نو، لكن هل في اي حد قال او كتب انه باكليتاكسيل بين قوسين تاكسول is superior than docetaxel in the adjuvant and neoadjuvant؟
لا. لا هي كان mainly toxicity profile، وكان بيتحط فيها بعد اذن حضرتك البيشنت preference، لان هم برضو الداتا كلها بتطلع على البيشنت preference. برضو usually the patients who are coming weekly rather than every 3 weeks sometimes تبقى bothersome، فبيطلبوا انهم يجوا every 3 weeks. ده نمبر 1. نمبر 2 الداتا اللي طلعت كانت ان الدوسيتاكسل فرق في اللوكال ريكورنس فري سرفايفل عن الويكلي باكليتاكسل بارقام very very low to be put as a recommendation in the docetaxel is better than the paclitaxel. And this is why if we open the NCCN guidelines, the most recent, you will find both regimens, both category 1, and it's according to the physician choice with the patient's recommendation or choice.
لان ده بينقلنا الى حاجه، معلش احنا بنستخدم الدوسيتاكسيل الباكليتاكسيل in the adjuvant and neoadjuvant, and when the patient have a metastasis مثلا for example after 1 year we use it paclitaxel again. على فكره this is not a very nice practice، لان still we have the room or place for docetaxel to be effective. يعني لو ما استخدمناهاش في الادجوفنت والنيو ادجوفنت انا كنت يعني مقتنعه شويه بالفرنش ترايل او باليوروبيان سايد، لكن اتس اوكي. انا عارفه ان في معهد الاورام دلوقتي بنستخدم باكليتاكسيل ان ذا ادجوفنت اند نيو ادجوفنت، لكن sometimes we withdraw the docetaxel يعني very far of any حتى metastatic disease. فطبعا
انا اي بليف حضرتك دي جايه من الكونسيرن بتاعنا احنا كاونكولوجيست من التوكسيستي. But if we can manage the toxicity then because الميتا اناليسيس ورد حضرتك في الميتاستاتيك areas it has an edge over the paclitaxel weekly already. ما فرقش في التايم تو بروجريشن بس في الاوفر اول ريسبونس ريت، انا متاسف، بس فرق في التايم تو بروجريشن واوفر اول سرفايفل ان سم اوف ذا ستاديز. ما بقولش انه اتس بيتر او اتس superior، بس if you get this data and you can manage the toxicity then you better go for it طبعا. يعني
الكلمة الأخيرة إن toxicity is bad when it is combined with anthracycline.
Yes,
you need growth factor. لكن docetaxel without addition of anthracycline very manageable toxicity.
Yes. Well, primary prophylaxis is very important rather than secondary prophylaxis, meaning I shouldn't wait for the toxicity to happen. I should predict it وادي الGCSF upfront from first cycle.
شكرا يا دكتورة.
Thank you, Dr. Heba. We know now, despite of all of the advances in the management of the breast cancer, still the chemotherapy is the backbone of the treatment of the many cases of breast cancer. Thank you, Sanofi team, and thank you, Dr. Ahmad, for this.